Started. Well, thank you very much, Nikki, and thank you everybody for coming today. It's a matter of bearing with me. Normally, the Health and Wellbeing Boards very much goes more smoothly because I've got Nikki Simpson, the Committee Services, right next to me, sort of nudge me in the ribs when I'm doing things incorrectly. So hopefully, Nikki will also still keep me on track, but it's maybe right. So I've. Yeah, I'm sure he'll keep me on track. And also Tony Jones will keep me on track because he's just asked, we adopted the protocol of only having the chair and speaker's camera on. That seems to work well, I think, in other meetings. So I'll go through a few things in terms of the meeting. I'm sure people are pretty much, getting used to a lot of these online meetings. So thank you everyone for coming and welcome back. It's good to get the Health and Wellbeing Board going again, although we only missed one meeting, but our last meeting was I think just a week or so before lockdown, so things rapidly changed over that time. We now find ourselves in a very different world, don't we, to the one we did when the last time we met. So welcome everybody. I'm going to read an announcement about the online meeting. And then we'll take the agenda. But can people keep their camera? I think people are already. Keep the cameras off and also mute unless they're speaking. We've got quite a few people. I think I'm probably going to make the wrong decision here. I think the best thing to do would be if people, when they first speak, could introduce themselves and the organisation they're from, so that everyone knows who everyone is. That would be great. So right, the first I'd have to do the chair's announcement. So it's about online meetings, and I'd like to inform everyone present that this meeting will be recorded in Microsoft Teams and will then be uploaded and available for repeat viewing on the council's website. Councillors, officers and partners attending will be asked to introduce themselves. This is for the benefit of the public and also to ensure that the clerk knows who is in attendance and that everyone can hear and speak to the meeting. To help me manage the meeting, if any members of the board wish to speak during the meeting, please can you indicate your wish to speak in the chat section on your screen and then wait to be called. This will avoid talking over each other. When not speaking, all attendees should put their microphones on mute, and obviously we've asked to put your cameras off. When called to speak, please unmute, put your camera on and pause for about 3 seconds to allow for the slight time delay in connection. If you are addressing the meeting, it would be best if you can have your camera on so that people can see who is speaking. However, we are aware that we're at the mercy of individuals' broadband services, so it is possible that loss of connection may happen, or if your connection is poor, you may find that it improves if you turn your camera off, so we will understand this if it is necessary. Okay, thank you very much. So the first item is, well, it's not actually on the agenda, but I always like to do the apologies. Nick, have you got any, what apologies do we have today?
Hang on. Yes, Chair. I've got apologies from Nick John, Peter Sloman and Kate Reynolds. I think that's all I've had.
Okay, great. Thank you very much. And does anyone have any declarations of interest against anything on the agenda? Now's the moment to declare it, or if it occurs to you during the meeting, then obviously indicate then as well. Right, so minutes of the last meeting held on the 13th of March. Hopefully people have had a chance to see them. Does anyone have any either points on them or particularly matters of accuracy? Now's the time to please raise them. I'm not going to go through each page. No, in which case we'll sign those off. Nikki, I'm not here. You're not here to just hand me the bit to sign off. I guess that do that electronically.
No, we haven't quite worked out how to do that yet. We've got to sort something out on all that sort of signing minutes off.
Great. Okay, so the first question then, well, the first main item is questions from the public, and we have two. The first, both are from Mr. Tom Lake, and the first question is to myself. So, Mr. Lake, are you there? Come in and please go ahead and ask your question. You were there earlier. I saw you.
Chat box is saying he's just left the conversation. So I don't know if he's left the meeting.
It does has to say it's left the meeting. I'm sure that was by. I'm sure that's not by intention. Tom's asked both the questions. Yeah, I could give him. I do want to give Tom a chance to get back in again. If he's just accidentally come out, he'll come straight back in again. I mean, are we allowed to just go back to, to questions? I can't see any reason why not. If
you're the chair.
The good thing is I'm always uncertain of my immense powers as chair, Tony. So, okay, so he's not come back in. What I propose, what I propose is perhaps we go straight on to the next item, and then we can always come back to questions if Tom hopefully comes back. I mean, if he doesn't return, then obviously Tom will be getting a copy of the answers that are written down and have all been circulated as well. Okay, so the next item is the impact of the COVID-19 in Reading. It's a presentation given by a number of people, so hopefully we'll see how this goes. And I'm not quite sure are you controlling the slides, Nikki? And I'm not quite sure who's starting it off. Is that you, David?
Yes, Chair. It'll be me starting off.
Yes, I am controlling the slides. I just need to share it. Somebody else is also asking to come in, so I'm trying to do too many different things at once. Let me just share the content first. Can people see that?
Yes.
Yes, thank you.
Good.
Great, thank you, Chair. So what I'll do is start off and then hand over to colleagues as we go through the slides. So to introduce myself, first of all, so I'm David Monday, the Public Health Consultant here in Reading. And the aim of this item is just to be able to provide update on the impacts of COVID in the borough and some of the work that's been happening in terms of recovery as well. And we'll go through a few different settings and partners for that kind of update. So it falls to me just to really summarise on what's happened with COVID in Reading overall. And I did promise the chair that I wouldn't turn this into a long epidemiology lecture. So what you can see on the screen there is hopefully a graph with a blue, a grey and an orange line. And what that's representing are confirmed cases of COVID in residents of Reading since the pandemic began in the blue line. And then just for context, you see in the orange line the confirmed case rate for the southeast, and then in the grey line for England. And clearly what you see is the spike in the first wave for Reading very much around mid-April. And as we move then on into May, broadly an infection rate that's been parallel to the southeast, at least, or maybe at least now recently has diverged a bit from the increase that's been seen nationally. And of course, there's limitations to this data, as I'm sure many people in the board have heard me say before, because this relates to those people who have tested, had positive, and we know, particularly early on in the pandemic, that testing was a very much a prioritised kind of modality for people being admitted to hospital and didn't pick up all of the community cases. So that's the kind of overall picture. In terms of the most recent, I've just added some numbers on the kind of slightly beige looking table on the left. And of course, the problem is as soon as I write down a piece of data for a presentation, it becomes out of date almost before I click save. So the numbers there are, I'll explain what they mean, and then I'll give you the kind of the latest update just verbally. So what we were seeing, so for the week that ended the 27th of September, is that if you take an average over those 7 days, we were seeing 4.3 new cases in Reading in a day. And we often just present the data not as an actual count of cases, but as a rate per 100,000 of population, which means that you can compare areas of different sizes to see what's happening with infection rates. So, and the Reading rate there was 2.6 per 100,000 in a day. Undoubtedly, in the last week or two, we have seen an increase in Reading, as has been noted nationally, and I'm sure members of the board don't need me to tell them that that's what's been occurring. So we're now at a place in Reading where it's between 6 and 8 new cases per day. Increasingly, the way this is being reported is actually kind of new cases per week. And at that per 100,000 kind of measure, as I described, to allow comparison. So Reading would sit at around 35 cases in a week per 100,000 of population, and that allows some of that kind of comparison. So we are seeing an increase in Reading now, and maybe not quite picked up on that graph that I showed you. And we know that an increasing proportion of people who go for a test because they have COVID symptoms are now testing positive. So that's the latest element, which isn't quite reflected in the numbers that are on the slides. But if we go to and before we go to the next slide, sorry, just to say, for members of the board, for members of the public, the link that's at the top of the slide there, that's Berkshire Public Health, and then it's the /COVID-19 dashboard, is a new site that's gone live in the last week or so, which brings together some different sources of national already data, but in one easy, usable place for each of the 6 councils in Berkshire. So if you want to look yourself at what's happening, then that is updated on a daily basis and is designed to be kind of simple to use and hopefully informative, although there's ways to feedback if you have comments about that. So next slide, please, Nikki. The other main thing I wanted to say, so just to touch on this, sorry, this is showing you what's happened in terms of death from COVID in Reading, and obviously quite a somber element of the data to talk through. And the blue bars that you can see going along week by week show you where there's been COVID-related death, and the orange death that is not COVID related. And clearly what you can see is that since the end of May, beginning of June, there's been virtually no COVID related death. And clearly that's something we want to continue to monitor. And that grey wiggly line that runs across the bars is showing you what is a usual death rate for Reading kind of for that week based on the season, because we know that the death rate is higher over winter months. So clearly something we're monitoring very closely as we enter colder and winter months going forward. And if we move on to the next slide, I think really the final thing for me to say was just to try and break down a little bit, if I can, the impacts of COVID per population group. So we know that COVID doesn't equally affect all members of society, and different groups in Reading have been differently affected. So when we first of all think about age and gender, we know, and I think everyone will be familiar with the fact that COVID is far more risky for people who are older in age, and the majority of death occurs in people that are over the age of 75. And what's been seen nationally on the column on the left is very much the same as what we've seen locally in that regard. In terms of gender, we do see more females testing positive than males, which we think is more about how people access testing than it is about true infection rates being different. But we know that some of the actual outcomes from infection are greater in men. So that's the difference that we see in terms of gender. And then the other thing to say about age, which I should have noted, is that we have seen an increase in cases most recently in some of the younger populations. So we don't get this broken down at a very kind of granular age level, but people certainly younger people and people of working age have had the greatest increase most recently. When we think about ethnicity, I think it's been well reported that there's been a disproportionately high impact on our BAME groups in the country. And that is similar to what we've seen in Reading. We do follow that national pattern where we seem to see more positivity, so more people with cases who are in our BAME groups than than you might otherwise expect. There's certainly a pattern with deprivation and people that live in our more deprived areas in the country where COVID seems to have a greater impact. It's quite hard to tease it out locally just because it's done as an area level indicator as opposed to an individual level. So it's slightly hard to tell you exactly what the position is in Reading for that, but we would expect that to similarly follow the same pattern. And then finally, on occupation, so some work was done by the Office for National Statistics looking at occupational groups and risks of COVID, and they're listed there in terms of what some of the groups are that were at an increased risk. And we are starting now through NHS Test and Trace and improved data sharing with Public Health England to get some occupational data through for Reading, so we can be monitoring that closely. But that's an area of, if you like, data analysis that's a bit of kind of work in progress. So there's one more slide, but that was again just to give members of the board a link if they wanted more information about the kind of geographical spread within the borough, and that link will take you to a national map which you can then zoom into the Reading area and look at where infections are occurring more. But that Berkshire website that I referred to earlier will also very soon have that same mapping feature on. So that's everything from my point of view, and I'm sure we'll take questions at the end of the presentations, and I'll be happy to answer anything. So if I recall, I think I'm handing over to adult social care colleagues, I think to John Dickinson, to give the next piece.
Thank you, David. Yes, hello everyone. I'm John Dickinson, Deputy Director for Adult Social Care in Reading. Just taking you through a couple of slides really, just to let you know where we are as a department. So if you could move on one slide, please. Thanks, Nikki. So just really breaking this into two parts really, firstly to look at operational, how we're working operationally, and also how we're working with providers and with our own provider in-house market. So the operational focus, I think back in March, no one, certainly no one working on the front line would have thought they'd be doing virtual assessments using their computer. But that is where we've got to. Certainly as over the last 6-7 months, people have really had to embrace the new technology, and we were lucky, I think, that we upgraded as an organisation into the latest Windows, and we had Teams software, so we could actually do this virtual face-to-face with people, with stakeholders, with colleagues, which really revolutionised the way we did our work. So we were fortunate in that sense. I think what I would like to say is, although we've embraced technology, we've also carried on doing face-to-face work. So the reablement team hasn't stopped. Our in-house reablement service has not stopped since March. They're still going in to see people, they're still reabling people and getting them back to their baselines. So some really excellent work by that team in particular. I think obviously supply of PPE, we will all have seen it on the news nationally, and of course locally that impacts getting PPE, getting the right PPE, managing the anxieties around that was a real issue, I think, for all organisations. So we had those issues. That's improved tremendously. But obviously, as we move forward, that's something we are still very much aware of, very much looking at in terms of this next phase and moving into winter, that we have full access to PPE. Everyone who goes out, any staff, have a risk assessment in place, not only for themselves but also for the individual that they're going to see. So the safety of our staff is absolutely paramount. We need to put them first, and then also clearly if they're fully prepared for the visits, and obviously we're not putting anyone else at risk. Work with health in particular, I think, and partners in general has been really strong. throughout this period. We've done some fantastic work getting people out of hospital, and we've had to adapt very quickly to the changes in the discharge guidance, which sees people coming home a lot quicker or back into the community a lot quicker than they were before. So that's the operational side. Moving forward, Nikki. So as you may or may not be aware, we have a number of in-house services in Reading Adult Social Care. So we have Charles Claw Court, which is an extra care facility, Focus House, which offers support for people with mental health, and they've both been running as well throughout this period, where we did make the decision to close temporarily some services. We closed Learning Disabilities Strathy Close day services, our respite service, and also our Older People's Day Centre, the Maples. So they were closed at the start of the pandemic, and we have recently opened up the Learning Disability Day Centre and the Respite Care Centre. Clearly have gone through all the governance and processes to get those safely operating, and the Maples is the only one that we haven't opened as yet. That has felt too risky to do. But what we haven't done is leave people without any services. So we've been in contact with those individuals, those vulnerable people, and looked at alternative care being sourced for them wherever possible. We've worked tirelessly with the market as a directorate to kind of tackle a lot of the issues that they've had similar to us around PPE, around managing COVID, and the teams within the directorate have to help those organisations and help those partners to really manage this effectively. There's been exchange of information throughout this period and will continue to be so. And I think as we move forward, I guess we're preparing for winter, and preparing. We can't do everything alone. We're conscious we need to strengthen our partnerships and keep building on those strong partnerships, having those honest conversations with our partners, putting our staff first, putting residents first, and just making sure we are fully prepared and we've learnt from the last 6 months that we're ready and energized to go for this forthcoming period. So that was all I wanted to say, Nikki. Not sure who's moving on to next. Rights of Futures.
Yeah.
Thank you.
Good afternoon, everybody. I'm Deborah Glassbrook, and I have the privilege of being the Director of Children's Services. I'm going to share with you what's been happening within Brighter Futures for Children in terms of the impact of COVID across all three areas that I oversee, that is schools, children's social care, and early help and prevention. So just wanted to start really talking about the schools, and of course our largest number of children go to schools. We have up to some 22,000 children in schools. So from March this year, schools, of course, as we know, got closed down for the majority of our children, but stayed open for our key workers and our vulnerable children only. And the number of children that went to school during that period was really very low, only in the hundreds for the majority of the time. But the schools were absolutely magnificent in terms of how they came together to provide for those children who were from the vulnerable groups. And then from the 1st of June, we had some reintroduction of our children, those reception year 1, 6, and then 10 and 12 in the secondary schools. And again, the schools were amazing in a way. They worked together to make sure that worked really well. They didn't open all at once. They didn't take all of those year groups in at once. They did it in a phased way to make sure that they could keep the children safe during that period of time. And then from September, again, some of them were slightly phased for a variety of reasons, but all year groups started back in full time from the beginning of September. Thank you, Nikki. So in terms of thinking about recovery for our schools, we've got 18,000 pupils from September going back to school. We've organised 11,000 bus journeys, and we've worked very closely with colleagues in the council and with the Department for Education to manage a travel demand strategy, and that's been very successful. We've undertaken 2,000 risk assessments for our vulnerable children, and the schools have used those throughout this period of time to make sure that they could provide the very best educational opportunities and keep their children safe. And then they used those as the children were reintroduced back to school. Our education welfare services have worked very closely with the schools right the way through this period to make sure that those children that were the most vulnerable, where we had the greatest concerns, that we could add capacity to the schools. And we've extended that offer right the way through to Christmas so that we can make sure there's the very best in reintegration as we possibly can. We do know that we've got some increased number of families choosing to electively home educate. And so our education welfare services are making sure that those children, of course, are getting the right education and making sure that that's just not a way of families not getting their children the education that they need to have. We did a project over the summer called the Transitions Offer, and that was because lots of children who were in year 6 going across into year 7 into secondary school didn't have the opportunities that they would have had done if we hadn't been in COVID lockdown. And so we did a piece of work with 70 children over the summer so that they could move from their primaries into their secondary school, and that was an incredibly successful piece of work. All but one of those children did reintegrate into or integrated into their school, and we are just evaluating the impact of that offer that we did over the summer. The only child, just for you to know, that the one child that didn't is moving abroad, and that was the reason that they didn't get into school. And then the other thing that we've been doing is testing and more testing in terms of COVID. I think the issues for the schools going back have been about getting enough tests. Schools were provided with 10 tests each, and then we've been talking to colleagues in the DfE and the Public Health England about them getting more tests, and we're pleased to be able to report that all schools that require it now, when they've used their 10 tests up, are able to get a supply of further tests to be able to use with individual children they're worried about in schools. There have been some issues around testing for teachers and getting local testing. Again, great partnership work with our colleagues and with David and his team in terms of actually raising awareness about the testing issues. We did have a teacher that had to drive all the way to Coventry at 6 o'clock in the morning to get a test, which I have to say I thought was beyond the call of duty, but that teacher did that, and I thought again that shows the level of commitment that teachers got to protect their children. Thank you, Nikki. So we thought we'd just share some interesting data for you from the end of September, that over 93% of our children are with plans, so that's with education, health and care plans in schools. And you may have heard in some of the press that there's been some concern about our children nationally who've got additional needs and special needs really struggling throughout this COVID lockdown. But we're very pleased to report that the majority of our children are back in school. We've got a rising homeschooling, as I've just suggested to you. So that has increased quite dramatically, and we have over 195 families thinking about elective home educating. And we've done a lot of work in that area, putting out frequently asked questions and making sure that families really do understand what they're actually signing up to if they're electively home educated their children, and recognising that, of course, once they've decided to do that, they do lose the school place. And so this isn't something for somebody to do very quickly or just because of a response to COVID. We're trying to help families really understand that their children will need a full education curriculum if that's what they choose to do. We've had small numbers of pupils and staff with positive results in their test. We've got about 9 children at the moment and 4 staff, so that is low numbers, but of course that does impact on the number of children that can stay in school and the number that are self-isolating over the 14 days as required. And we have got a small number of schools that have had to close in some partial way or another due to lack of staff, and we do have an early years provider that's had to do the same. So we are very aware of what the impact is of COVID and how we're managing that on a day-to-day and week-to-week basis. Thank you, Nikki. So in terms of communications with the schools, throughout this period of time, since the beginning of April, we have provided the head teachers with briefings. So that's a written briefing 3 times a week to keep them up to date. We have meetings, dial-ins or team meetings actually as they are with the primary head teachers. So we'll often meet with 30, 35 of them every Wednesday. So Kate Reynolds, our wonderful Director of Education, and myself meet with them on a weekly basis where we can share information with them and they can ask us any questions and we can escalate that through to the DFE because we do have daily contact with the Department for Education. We have that on a Teams meeting 3 times a week, and then we have email communications twice a week where we do escalate issues. So issues about the tests, as I've just mentioned. One of the issues for us at the moment is about wanting to make sure that our colleagues in the independent sector of schooling are also participating in data collection and the requirement to report children who've got COVID, etc. We have a weekly meeting with the unions and that's a really good collaborative relationship, and Kate gives me a daily update as she does with the chair of the Brighter Futures for Children board so that we know what's going on a day-to-day basis. Thank you, Nikki. So moving on into thinking about social care and social work, what we saw originally was an initial reduction in referrals, which is what we'd anticipated as families went into lockdown. There was less communication, less visibility for families, quite clearly from schools, with the police and indeed with health. But we have seen those levels of referrals return to normal now. And again, we'd anticipated that as lockdown lifted. What we are seeing, and which is quite worrying, is an increased complexity in both the new referrals that we're getting and the existing family situations. And we have seen a substantial increase in those families where there's non-accidental injuries. So those are physical abuse, and where small children are sustaining really very severe injuries, and we're seeing that again across the country in a way that we haven't seen that for many years in social work. Similarly to our colleagues in the adult services, we undertook risk assessments of all of our children. We did RAG ratings for every single one of those children, and then we put into visiting arrangements depending whether those children were RAG rated red, amber or green. And throughout this period of time, we have made sure we have done face-to-face visits to see the families and their children in their homes right through, and we are now visiting all of those children that are RAG rated amber as well. And those RAG ratings were risk assessed on a weekly basis through a risk panel that we had in place. We have seen an increased number of children on child protection plans. Well, of course, that relates to what I've just said about the increase in non-accidental injuries and the complexities we're seeing in the way that families have been impacted by COVID and the difficulties of trying to manage when they are in closer proximity without the schools, without health visitors, without some of the normal support networks that they've had around them. And what we have seen coming into the country is an increased number of unaccompanied asylum minors, a big increase into Kent and to Portsmouth. And there is a request, and indeed going to be a recommendation, that we take more children who are unaccompanied asylum seekers going forward to support those children who are in that situation. Thank you, Nikki. So the response from to manage COVID is, I say, we've had risk panels in place and we've continued with those. We've increased the visiting. We've put in place a demand management strategy, which is looking at the significant numbers of referrals that we're getting from colleagues in the police, in health and from schools. And we're also looking very much at sufficiency, because we have actually managed to keep our children in care numbers at the same rate as pre-COVID, which is actually very unusual. Most local authorities are seeing an increase. We're managing that very well because we have a really strong supportive exit strategy for those children that it's appropriate to come out of care, and we're also managing the number of children coming into care. What, again, similarly to colleagues in adult services, we've seen very strong partnership working during this period of time, and I think that would be one of the real positives that's come out, if I could say that. That's not quite the word to say, there's something positive come out of COVID, but it has been something that has been really strengthened during lockdown with all of our colleagues. And then the other thing in terms of responses, it's given us a greater opportunity to really quality assure all of the work that we're doing, and making sure that the learning from what we've been doing is taken forward, so that if we do go into a second wave, or depending on how long we are in these sorts of situations, we can take the learning to make sure that we stop doing what we don't need to do and do more of what we do need to do. Thank you, Nikki. So then the last section is really about our early help and prevention. We had a reduced provision for our early years settings, so our nurseries and childminders. It was unfortunate that the government made a decision to offer furlough and then did a U-turn on that, and that's left our early years providers in some tricky positions, and we are concerned about the financial viability of some of those settings. We're very clear that we need to make sure there's sufficiency for our little people, and that's something we're working on at this moment in time. Similarly to social care and adult social care, risk assessments were undertaken for all the early help work, and they ran the same RAG ratings and visiting arrangements. What we have seen, very sadly, and some of you all have read about this in the press, of course, is that we've had some increase in serious crime. We've had 3 stabbings, and they have included 3 young people that come from Reading. We have got a youth offending service, which is very good indeed, has been working very, very hard over this period of time, but again seen a reduction in crime with our young people overall, and indeed we only have 37 young people open to our youth offending service in Reading. Thank you, Nikki. So finally then, just to say, we continue with the risk assessments. We've got a very strong One Reading Children and Young People's Partnership. We're delighted to have Councillor Terry, who chairs that for us. That's a very strong partnership and is going from strength to strength. And the final point was just to say that we've got a child in need project that we're running through early help and prevention. So this is where it's overseen by a social work manager, but is actually staffed by family workers. And we're just in the process of evaluating that. That's being very positively received for the majority of families, and is supported by our improvement advisor, Nick Whitfield. And that's something that we'll be excited to be able to feed back to you at a future board. Okay, thank you very much indeed.
Thank you, Deborah. I know you put questions there. Is it okay if we take all the questions at the end for the...
Absolutely, yes, thank you very much.
Thank you. Right, is it Rachel?
Yeah. Hi,
Spencer.
Rachel Spencer, Reading Voluntary Action. I am actually going to turn my camera off because I don't have the best sound. So I'll leave it for you to shout if you can't hear me. Can you hear me okay?
You're a little bit quiet, but I guess people could always turn up the sound on their machines. You go ahead, Rachel. Yeah, I can hear you, Rachel.
Okay. So I've just 2 slides from me. So it's Rachel Spencer from Reading Voluntary Action. First slide is looking at how the voluntary and community groups responded during COVID and are still responding to the immediate impact. And then the second slide is really looking at priorities and preparation for the winter months. So the stats that you see on the slides there are activities, that's to August. And that was really in response to calls for help via the One Reading Community Hub. Very much a partnership. I will mention the partners, RBA and RBC obviously, but also Healthwatch, Age UK Reading, Communicare, Ready Food, Engage Befriending and Redibus. And all of those organisations really kind of stood up services and prepared their volunteers within a matter of days, within the first week. And there's a wider partnership as well, which also included our community centres and others. And they provided essential contact in the neighbourhoods and also practical support. And I've got hundreds of examples of that, but I will just mention a few if that's okay. So WCDA and Whitley, their volunteers distributed over 5,000 parcels to the end of August in the local area there. And the Weller Centre in Amersham Road in Caversham, their volunteers supported 227 households throughout lockdown. and 72% of those had not actually had any contact with the centre before. So we had 4 church groups and hubs across the town who were supporting with the shopping. We also had an amazing response from the mosques. The Alexander Road Mosque in particular at one point was sending out over 100 hot meals a day. So all in all, a fabulous community response. But as well as the practical provision, there was a huge effort to try to maintain the support networks for people. And we've recently estimated that the sector facilitated more than 4,000 Zoom sessions for their various beneficiary groups during lockdown. And that's included all sorts of beneficiary groups, but people of all ages really, who were isolated and anxious, often alone, and managing really difficult circumstances. And for most of those groups, that would be a new experience, in the same way that John was mentioning, getting their staff and volunteers, making sure they had the right equipment, knew how to use the equipment, how to facilitate a session on Zoom, but also then thinking about the members of their groups and how they were going to access and be able to participate in group sessions. So it was a huge learning curve for all, but most of the groups would say that there were some real positives that came out of that, and that they plan to include some kind of online activity even beyond COVID, if we can imagine such a thing. So then moving on to the next slide, if that's okay. Okay. So I'll come back to the first point there, but the priorities that we're planning for are really around mental health and anxiety, supporting people to become or remain mobile. Mobility has really become an issue during lockdown. Making sure people can access the internet, building capacity of groups who are supporting our diverse communities, and developing a volunteer force. And we've recently opened the resource and training hub for volunteers, and that's really building on the motivation generated by the crisis. So we're planning response to potential future lockdown, but also help with recovery, but also responding generally to any emergency. And another really positive thing that has come out has been the Voluntary Sector Emergency Partnership, which is now a national partnership. Meets our local cell meets weekly, and that's led by the Red Cross and React, and they're definitely going to sustain their services and their offer way beyond COVID as well. So we're looking at various scenarios and workshops around emergency scenarios, which is great, exciting for the volunteers. And finally, the priority around mitigating the financial impact, and for us a particular focus on supporting people back into employment as quickly as possible. So then going back to the top bullet there, so by the end of November, there will be 6 social prescribing link workers really connected into our GP surgeries across all the neighbourhoods, receiving referrals from both health and social care partners. And those social prescribers really get alongside people and build trusting relationships and support them to access all the offers that the voluntary sector provides. And I think, to be honest, that offer does fluctuate a lot at the moment, probably the same for everybody, along with the guidance. But for most, they have been able to continue and be creative and albeit offer adjusted services. So that's a snapshot from me, and I'll hand back to Councillor Hoskins, I think, for questions.
Thank you very much, Rachel, and thanks everyone for that presentation. Yes, I'm looking for any questions, any points anyone wants to raise them. Mandy, you put your hand up. I'm sort of kind of referring the chat, but Mandy, I recognise you've put your hand up. Would you like to go ahead?
Thank you, Chair. And firstly to say thank you for those really excellent and informative presentations. They were really good. Thank you so much. Just 2 questions from me. Do we have now a fully updated COVID plan, given everything we've just heard and all the excellent work that's going on, but also what's going on with numbers at the moment. So do we have a plan? And secondly, what mechanisms are we using to communicate with our local community what's changing and developing and what's available locally in terms of support?
Great, thank you, Mandy. I think that's probably for you, David, Monday.
Thanks, Chair, and thanks, Mandy. But I think two important questions. So firstly, in terms of the COVID plan, so I think partners of the board, not necessarily through the Health and Wellbeing Board, but through other forums, will be familiar with the outbreak control plan that we published an executive summary of towards the end of June. And since then, we've been working up the fuller version of the Reading outbreak control plan. That's now with Public Health England for their review. So is in that kind of final stage of, if you like, kind of vetting and checking. Although I say the final stage, I think we all we'd all recognise the fact that that we're never going to be able to write an outbreak control plan and think through all of the eventualities and the various facets required, and that being a static document. So we know, for example, the data is changing, but we know that the data that is available to us changes. We know that there's been discussion over the last few days about how what kind of threshold will be put in place for different tiers of intervention in the country. We know that the kind of methodology of contact tracing, although the National Test and Trace programme is running, we know that there's an opportunity for us to also have a role locally. So a number of key elements change. And I think the name of the game is about, yes, getting this plan, say, vetted and signed off by Public Health England, but also remaining fleet of foot in how we are responding. So I think that's the first thing. On the second question, in terms of how we're communicating with residents in Reading, we're doing a number of things to support that work. So development of infographic material, development of kind of local resources, signposting to our national ones. We're very conscious that we need to be reaching out to groups that can inadvertently be marginalised, sometimes in contact with health services or just in general receipt of kind of health information. We've recruited a new person to help us with some of that engagement, work, so that we understand well needs of those communities that are sometimes less well represented, and trying to make sure that those connections work, and also doing quite a lot, whether it's through social media or through particularly targeted media channels at whether it's younger groups or whether it's at students or at particular kind of if you like segments of the population. In terms of the actual then council services that are running from the RBC perspective, we've got a dedicated part of our webpage which gives residents the kind of insight into what's available and what's running, and how they access council services, and that's something that we will keep updated as inevitably the picture evolves as we kind of go through the coming months.
Great, thank you for that response. Any other? I've got a couple of questions. I haven't got anyone else indicating, in which case I will ask mine. So the main one I wanted to ask actually was to Deborah Glassbrook, and it was, I think you touched upon, or maybe in passing, so the concerns around over lockdown, what impact that might have on families, concern around that, families are together, there could be an increase in domestic violence and safeguarding issues like that. And I suppose a slightly more reflection on that, I'd be quite interested in your view about that locally, but also have we got concerns around, don't have a crystal ball, but I think it's fair to say that we may be seeing a lot of people losing their jobs, going on to the benefits that exist, and expect to see poverty rising. So quite a lot of strain for families, and I just wonder whether that was something that was a concern and has been considered for the coming months. Thank you.
Yes, yes, thank you for that question. I mean, I don't think there's any doubt at all that we, as we went into COVID, predicted that this was going to have a major impact on family dynamics and family support. Because, of course, when we were in total lockdown, families couldn't even reach out to other family members or friends and were left entirely to manage on their own. And we do know that for many of our families, they are not particularly resilient. They don't necessarily have the self-control or the strategies to manage. And in fact, I think lots of people who have all of those things have actually struggled through lockdown. So for some of our families, this has been an incredible strain. And we have seen a dramatic increase in domestic violence and domestic abuse, not just of women, but also of men. And of course, it means that more and more of our children are seeing and witnessing those sorts of behaviours. Again, there's no question that as people lose their jobs, their sense of identity, their ability to provide for their families and to live the lives that they believe they were going to be able to live is going to be impacted. And again, it's how people manage those reactions and their behaviours in those times. So I think we are going to see increasing numbers of complexity and increasing numbers rise. I think what we need to be doing is to be using what we've got in our communities. And as I said earlier, we've got very strong partnerships, very strong opportunities. So I think what it is about continuing to mobilise our universal services and our communities to help identify those families, to be able to provide support at the very, very earliest point. Because what we absolutely do not want to happen is for children to be left unwatched and unseen, in such a case that their situations escalate straight into what would be specialist services, where they become straight into child protection or, straight becoming into care. And we have seen some unusual situations, as I was mentioning earlier, where we've got families who we would have never anticipated seeing coming to us for services, and children really sustaining very, very severe injuries. So I am worried about that, but I do believe we've got strong partnerships, and I do believe that we can actually provide really strong wraparound services. The difficulty, of course, is it's very difficult, and if only I were able to predict when a family is actually going to snap and where they are going to do something very severe to their children and indeed to each other. So it's something we are having conversations with across the partnership and indeed nationally. To talk about the number of resources, and of course this is where the difficulty with some of the cuts and the budgets that are going to impact, where we want to make sure that we're not losing those services that are going to have the very best impact for our children.
Thank you, Deborah, for that response. Any other? I haven't seen anyone else indicating, in which case I'd like to say thank you everyone for those presentations. It was just gives a snapshot of the immense amount of work and activity across the entire town, and working in partnership. And as Deborah just touched upon at the end, I think makes it all the more worrying the budget gaps that exist in councils across the entire country, when you can see how important increased local action and services are going to be over the coming months, and we're faced with huge budgetary problems as a result of the government not fully funding the costs of the COVID pandemic on local communities. So really tough times ahead, but it's great to see, and as Deborah also said, is that the strength of those local partnerships. They're going to be really tough times, but working so closely together, I know we can try to get through them the best we can. And I'd just finally like to say, really welcome the social prescribing workers moving into the local areas. And that's really exciting, and might be tricky times to deliver that over the coming months, but I think it's something that'll be a huge and important future in terms of health and wellbeing in the town. So really excited to see how that goes. Okay, well, thank you very much for that. No one's got anyone else they want to ask, in which case we'll move on to the next item, I think I've lost my agenda underneath all these papers. Here it is. So actually, Mr. Lake, I think, is still with us, Mr. Tom Lake. So we're going to jump back to questions. So, Mr. Lake, fire away.
Thank you. Thank you very much. My first question was comparing the suppression of SARS-CoV-2 in Wuhan. By comparison, Reading would need about 90 public health workers to effect the sort of suppression that was carried out there. It would need control of testing and test data, and it would need to be able to isolate some people away from home. And of course, that would have to we're not an island, so it would have to go on throughout the country. Can you compare our current resources with those indications?
Thank you, Mr. Lake. Yeah, and that question is to me as chair of the board. Quite a tough question to make those comparisons there, but so I'll try. So since the novel coronavirus was first identified as a potential threat to the health of the people of Reading, we have mounted a comprehensive response. Those at the forefront of this work have a range of roles to ensure that the response is effective. This includes our Director of Public Health for Berkshire and the team of consultants, specialists and data analysts that she leads. It incorporates the Public Health England team for the Thames Valley with their dedicated Berkshire West consultant and team. Within the council itself, we have our local public health and wellbeing team led by our consultants. However, others don't simply have public health in their job title, have also been and continue to be central to our response. For example, our Emergency Operations Centre team and our Environmental Health Officers and Regulatory Services team lead on our work to ensure that Reading is a COVID secure town. Partners around this board have also been instrumental in our response work, which you've seen a fair bit of that with that previous presentation, and obviously our NHS colleagues as well. But also the Health Watch and the voluntary sector in ensuring things like the One Reading Community Hub have operated effectively, and the most vulnerable in Reading are supported at this time. I don't think it's possible to do a total headcount with these individuals and roles, but I'm sure it exceeds 90 by a long way. In terms of data and testing, we have daily information available to us on the number of people having tests for COVID-19 in Reading, whether they test positive or negative for the disease, and allowing us to track the virus ever more closely. Local testing options for local residents are expanding, and despite national challenges, we now have a regular mobile testing unit at Prospect Park. And as I have made previous reference to, we're working towards a university to establish testing on their campus too for students and the local community. It is true that the national outsourced test and trace system is well deserving of being widely described as a shambles with inadequate capacity for testing, and the national contact tracing system now, on the most recent figures, failing to reach 31.4% of the close contacts it receives of the people who have tested positive. Whilst the national test and trace is working better in Reading than much of the country, I've no doubt that a properly resourced local public health coordinated system here would have provided a far more effective service. Contact tracing and isolation is coordinated by the NHS Test and Trace, and across the UK and in many other countries require people to be isolated at home with their household if they develop symptoms or test positive for COVID-19. The scientific evidence shows that this is effective in reducing the spread of the virus and pushing the R value down as far as possible. The main issue in my mind is the scandalously inadequate financial support for people who have to self-isolate, meaning that many people cannot afford to, and may also lead to people being unwilling to pass on to contact information for friends and family who they think could have money problems if they have to self-isolate. The government's own SAGE advisory group estimates that less than 20% of people in England fully self-isolate when asked to do so. That's my answer. Slade, do you have a supplementary?
Yeah, Mr. Chair, I would just ask a supplementary in relation to your last point. With regard to full self-isolation, I understand that financial concerns might be dominant, but there also apparently are some people who just go out to do their shopping or so on when they shouldn't really. Now, I wonder whether Reading is yet getting sufficient data to be able to offer direct advice and support to people who should be self-isolating.
Yeah, thank you, Mr. Lake. As you know, I passionately believe that local test and trace systems should be in place across the country. We don't have that. However, over a period of time, areas have opportunities to see if we can develop local capacity within the system, as Mr. Monday was referring to. We are in we're in discussions with the Department of Health about developing that for this town. So my belief is that local connection and support will be very much preferable to allow us to locally signpost and support people to self-isolate. So that's what I believe needs to happen. Obviously, we're working towards getting that in place in Reading.
Thank you, Chair. My second question was to ask for an indication of the state of NHS waiting lists, especially in cancer diagnostics and cancer treatment, child mental health and elective orthopaedics and so on.
Hello, Sam Burrows here, Deputy Chief Officer for the CCG, and Mr. Lake, if you don't mind, I will answer that on behalf of the NHS representation at the board, if that's okay. Bear with me, it's quite a long answer. So for urgent and cancer demand, the Royal Berkshire Hospital is returning quickly to pre-COVID numbers, being referred and attending the trust. Throughout the pandemic, they have continued to operate services where safe and sensible to do so. Wait times for cancer appointments, diagnostics and treatments have and continue to be prioritised, and they are returning quickly to their own internal expectations on wait times, which often go further than the national expectation. The longest waits for cancer care and the overall size of the pathways over 2 months have been dropping at pace, which is really positive. The size and profile of the Trust cancer waiting list is returning to a more normal shape. All of the Trust's diagnostic services are open and operating at full capacity. The Trust continues to prioritise cancer and urgent diagnostics, with routine priority work being seen in chronological order. Routine treatments, including routine elective orthopaedics, are taking longer, and the Trust has a backlog of work that is being prioritised alongside the urgent workload. There are a number of complexities in the routine pathway, largely through patients choosing not to attend and the result of COVID safety guidelines and restrictions. However, the Trust is continuing to maximise the use of capacity to see and treat patients as quickly as possible. The Trust did not close its doors to new referrals throughout the crisis, instead deploying a solution allowing GPs to refer and enable the creation of work lists for clinical triage. With triage in place across the Trust and a huge expansion of digital care delivery, the Trust has been able to continue to manage a level of demand that can be benefited through either advice and guidance or virtual telephone assessment. Considered together, this has meant that whilst they do have a backlog of extended waits, they are able to focus a larger proportion of their capacity to see these patients, particularly in the outpatient setting. It's expected that the size of the top of the waiting list will continue to grow over the next few months, and teams are focused on communicating with patients to agree appropriate next steps. However, with fewer patients moving through the lower parts of the waiting list, either because of reduced demand or as a result of the new pathways that have been put in place in the COVID response, there is confidence that this profile will reverse later in the year as they aim to stabilise and recover the waiting list as quickly as possible. With regard to child mental health waiting list, average waiting times in the common point of entry in September was 1.2 weeks. For those young people needing a face-to-face appointment following an initial telephone or video triage, the average wait to a second contact was 3.2 weeks. We are monitoring the common point of entry closely and working hard to keep waiting times down as referrals increase. Mr. Lake, I've got some data tables and graphs that I think would offer some additional colour to the answer I've just given you. I've submitted them to Nikki and through to the chair. I'm sure we'll be happy to make them available to you outside of the meeting.
Thank you very much. Thank you both for your answers.
Thank you.
Mr. Lake, did you have a supplementary?
No, no, thank you very much. That was very helpful.
Thank you for your thank you very much for your questions, and I should also say welcome Sam Burrows as well to the board. We're very pleased to have you here.
Thank you, Councillor.
Thank you. So that's the that was the questions. I realised I didn't ask Nick if we had any petitions, but I'd be surprised if we had, so I didn't know about them.
No, Chair, they're Anthony. Just to point out that the questions and replies are actually in the chat. So if anyone wants to look at those that data, I've put it in the chat here, and I'll put it on the website later as well.
Thank you.
Thanks,
Thank you very much. Right. Okay. So the next item is item number 6, and it's the Director of Public Health, Berkshire, Tessa Linfield, to present on her annual report. Tessa, it's all yours.
Thank you very much, Chair. And I'm just putting the slides up to share. I'm hoping that you can see them. Can people see those?
Yes, I can.
Yes.
Good. We always like it when the technology works, don't we? Which is great. So I understand that the report has been circulated around the group so far before the meeting. So that's great. Thank you.
I've put it in the chat as well, Tessa. So if anyone wants to look at it, it's the documents at the top of the chat. Yeah,
brilliant. And Reading is very first in the list of people to look at the annual public health report this year. So yeah, you've got the first look, which is great. So you'll remember that the annual public health report is an opportunity for me to do something that's an independent report to highlight an issue that I think is important. And the way that I look at this across Berkshire is that I look at the annual public health report not just to present loads of data, but to actually start some conversations, to kind of kickstart some thinking, some ideas across our county. And I really thought this year, you couldn't ignore COVID, could you? So really, the annual public health report this year had to be about COVID, because not just because it's a public health emergency, but just because of the reverberations that it's caused in all areas of our lives. And really because COVID's shone a real light on our society, bringing the inequalities that we see across our population into sharp relief. And it's also, so it's really done a good job, I think, of really not only shining a light on inequalities, but really teaching us that there might be a different way for us to organise ourselves as we look into the future. So that I think that we have an opportunity here to look at how we organise ourselves for recovery to do a better job, so we build back better. Now, I think we're all at the stage where we recognise the devastating and direct effect that COVID has had on some members of our community. And I think we're all at the stage now where we either know someone who's lost a loved one or lost a loved one ourselves, or know somebody who's been really ill from COVID. But the longer term impacts on the way that we all live and work and the places that we live and work in are really only just starting to come to light. So as I said, this report is intended to be a conversation starter to help us think about how we can organise ourselves as we recover from COVID as a society to better tackle some of those inequalities that are prevalent across our society. So this slide is a slide from the British Medical Journal, and it's their in memoriam page of the doctors that have died of COVID so far. And it seems strange to start a presentation that's essentially about inequalities by looking at a group of highly educated and fairly privileged people. But I think if we look at the faces in those pictures, and two of those doctors are from Berkshire, Dr. Peter Kintun, actually from the Royal Berks Hospital. But when we look at it, it's a real illustration for me about how we can see this unequal burden of COVID. We know that healthcare workers and people in other professions are much more likely to be exposed from COVID. And we can see here that we have a lot of people from Black and minority ethnic communities on this page, and we know that they are more likely to experience harm from COVID than their white peers. So COVID really has shone this light on inequalities across our society. And COVID's not like a usual public health emergency, although I'm not sure there is such a thing as a usual public health emergency. It's often something like a big fire or a chemical leak or a particular outbreak, but something that's time bound and has an end point where we have a definite switching point from response into recovery mode. So we look to put things back together in the way that they were before. But COVID's not like that. It's not going away. We need to learn how to control it better and protect ourselves better from it, but it isn't going to be stamped out like we'd stamp out a fire. So I think we can see that COVID's really changed things for good. And while it's undeniably caused some harm, there are real opportunities and lessons that it's taught us. So when I was thinking about the topic for the annual public health report this year, I was really inspired by the concept of building back better. Which the WHO have promoted quite widely, and it first sort of came into post-disaster parlance after the 2004 tsunami, and then really gained prominence after the Christchurch earthquakes, and it's being talked about quite a lot as we talk about how we plan for how we're going to recover after COVID. And I really wanted to take some of the learning from other disasters across the world to think about how we can apply some of that learning into our response and recovery to COVID. And we might think it's a bit early to start talking about recovery because we're still in full-on response mode. In fact, we're getting more and more into response mode as the cases increase, as we see our second wave of COVID. But we know that the way that we respond now, as we see more cases now, will really determine what we need in recovery and what is possible in recovery. So it's important to talk about now. It's never going to be too early. So it's worth taking a minute just to think about the different sorts of harm that we will see from COVID. And I like this graphic, which we found on Twitter. So it talks about the direct impact of infections, so people who become sick and die, and also that we've already heard in discussions so far about the direct impacts of countermeasures for COVID. And we've already seen rises in demand for mental health services, as well as people struggling to get fully well again if they've had COVID themselves. But it's really important that we don't forget those indirect harms. And again, the question that we just heard referred to those, from disruptions to health services and care services, so that you can't respond in the same way to health emergencies. We know that we saw delays in people calling ambulances for chest pain early on in the pandemic, or that people might feel uncomfortable about taking their child to be vaccinated at a healthcare facility if they're worried about COVID, for example. And so those are the kind of indirect impacts of COVID on people's health and well-being. But by far the largest impact on people's health and well-being is going to be around that long-term impact on our economy and the way that we live our lives. And we've spent a lot of time at this Health and Wellbeing Board talking about wider determinants of health. And I think that we mustn't stop thinking about wider determinants as we start thinking about the impact of COVID and our recovery, because that's where the opportunity is for us to really protect people's health and well-being in the really long run. So the next slide is actually a graphic. It's hard to see, I know, because it's quite small, but it's on page 11 of the report. And this has been prepared by our colleagues at West Berkshire Council and is actually getting a lot of prominence. It's really popular across the country. So congratulations to them, because I think it's a really good slide. And it really demonstrates the different aspects of health and well-being across the life course that will have been impacted by COVID. And we're adding to this slide all the time. So we've heard a lot about the very direct inequality of COVID, in that older people are more likely to be adversely impacted than younger people. People who have pre-existing conditions like heart disease or diabetes are more likely to become seriously ill or die from COVID. And we know that our Black and minority ethnic populations are experiencing more serious illness as a result of infection. But it is important that we think more broadly about impact across the life course as well, as we think about recovery and inequalities from the indirect consequences of COVID. And we know that as we look at recovery, we need to look at the impacts and benefits, not just at different stages in our lives, but between different groups. So the way that we measure our recovery needs to look at that differential between different groups around deprivation or different ages, so that we're monitoring those inequalities and looking always to try and close gaps, not widen them further, which has been the real risk of COVID. So just moving on to what's in the report. So we've split our 10 things to think about into 3 broad sections, which you can see listed on the left-hand side of the slide there. And within each of those sections, we try and answer these 5 questions about why this particular issue is important in recovery, important for inequalities, important locally. And then we look at what's worked elsewhere. What's the learning here from other disaster recovery experiences that we might be able to apply to COVID? And then what sort of measures might we be able to include in our recovery work to see if we're on the right track or not? So I'm going to dig into some of the issues that we've raised. Inequalities is throughout this. You'll be sick of me mentioning it by the end of the next few slides, but inequalities is our number one. Then we talk about employment, and you'll remember in last year's annual public health report was all about work and health, and we talked quite a lot about inequalities between different groups in our boroughs who had different risks of employment insecurity. So we talked about that young people were particularly at risk of being insecurely employed, with more work in the gig economy and 0 hours contracts. Those inequalities are showing up as we look at employment data around COVID. Women and young people were more likely to be furloughed. Women and BAME communities more likely to be in jobs that expose them to COVID. And in our lowest earning 10% of our community, 80% of people are employed in sectors that were shut down, compared to only 25% in the highest earning group. So that we've excluded key workers from that, because clearly key workers, although they're extremely busy at the moment, are reasonably securely employed. So there's definite inequalities showing up in the employment situation as we work our way through this pandemic, but we have really learnt about new ways to work, and there are real lessons for us to take I think, moving forward. We can capitalise on our greener ways of working and our work-life balance lessons that we've learnt here. And there are opportunities for tweaking the way that we look at our recovery towards education and skills that meet the demands of employers and promote social mobility. There's some good examples of programmes in the report in Greater Manchester and Leeds, for example. And again, it builds on last year's annual public health report, where we talked quite a lot about quality work rather than just any work, and that the quality of the work that you do is really important for your health and well-being. And there's an opportunity for us to look at those groups that are particularly impacted by employment insecurity because of COVID, to make sure that we're reinstating quality work, not just any work, as we move forward. Another group that we look at in some detail is children and young people. And again, we heard earlier on about the impacts of COVID on that particular group in Reading. And this slide gives us some summary data about some of the vulnerabilities in our population of children and young people, who it's thought will be hardest hit by the countermeasures in place for COVID, so social distancing, disruption to education, etc. And it's interesting, isn't it, because young people are really bearing the burden of prevention of COVID and the indirect impacts of COVID, but not the actual burden of the illness themselves. So they're paying quite a price in keeping everybody else safe, and I think that needs to be recognised. And the evidence is really strong from the experience of other major incidents, such as the earthquakes in Christchurch and Grenfell, that really listening to young people and using their feedback to inform recovery plans and supporting families and trusted relationships are absolutely key to a strong recovery. And if we don't get that right, we won't be doing a good job by our young people, as well, of course, as making sure they get the services that they need in the same way as they did before, or differently from all the things that we've learnt during COVID. And we've also heard this morning about some safeguarding issues around domestic violence. That we know that during natural disasters and catastrophic events around the world, that there is a known increase in the risk of abuse that's associated with incidents of this nature. And we know that it's not just during the incident itself, but that the rates of abuse stay higher during recovery as well. So it's not just at the time of lockdown, it's likely to be continuing now lockdown has been lifted. And that evidence is really strong. It was really strong when they looked at Katrina, at the 2009 Australian bushfires and the Haiti earthquake. And there's really strong evidence about that, about there not only being more incidents, but that incidents are more serious. So it's a really important thing for us to continue as we work through recovery, not just during our response phase. And we know that there's evidence out there about actively inquiring about whether abuse is taking place, and in providing new ways for victims to seek help. So the silent solution, where people can dial a code into the phone if they're calling the police without having to say anything, and apps like Bright Sky. So there are some really innovative solutions coming our way that we need to make the most of. Mental health's also been mentioned in the meeting so far. I feel like that the items I was listening to before I started talking have been a really good preamble, hopefully, for this report. And we know there are really clear links between mental health and inequalities prior to COVID, and they are likely to increase because the evidence shows that more mental ill health comes to light as the incident continues and as recovery starts. And we mustn't forget our employees in this. We know that services after the Grenfell fire had to move into like really screening and testing staff for their mental well-being and working really hard to destigmatise seeking help. So again, we know that we can measure prevalence of mental health conditions in our population, and we also need to be looking at uptake of services as we move into recovery and looking at that differentially between different groups to make sure that we're not enhancing health inequalities, but we're actually looking to close the gap. Another issue we look at in this year's report is around the environmental impact. And we know that during lockdown, there was a 17% fall in CO2 emissions in April 2020 compared to April 2019, which people are claiming is a proof of concept that pollution levels are responsive to policy. Now, I'm not recommending that lockdown is a policy for reducing the environmental impact and reducing carbon emissions, but it does show us that it is possible, that change is possible. And we look at the increase in the amount of cycling that was happening in May, June, July this year, that we know that given circumstances that we've also changed the way we take holidays, overseas travel, more people having holidays at home, and we can build on this. There's less consumption of throwaway fashion in the last few months, for example, and we can build on this as we move forward. Air quality has always been an issue for us in Berkshire, and we know that the people who are impacted by poor air quality are not the people that are contributing to it. So a real inequality there that, again, we need to look at carefully as we move through our recovery planning. And there are some ideas on measurement in the report there. This slide is around engaging with communities, because while there isn't an awful lot of evidence to show how well engaged a community is, which is why I've used this electoral turnout slide, which probably isn't the best measure, but it is quite interesting if you look at the rank of local authorities by deprivation versus their electoral turnout in the 2017 election. You can see that there's a clear trend in terms of the more deprived the place, the less the turnout, and that could be an indicator of how well engaged people feel with decision makers in their community. And the infographic at the bottom of the slide is quite old data from the Place survey, but it does show that we don't have particularly high levels of engagement within our community in terms of decision making. And as we move out of the response phase for COVID into recovery, we're going to need to really ramp up our engagement with communities, because the evidence is really strong that if you don't engage with your communities as you rebuild after such a major incident as this, you won't get such a good recovery. So there is a real opportunity for us to really think carefully and look in the mirror to think about how we're getting that engagement right, and how we're particularly looking to engage with people in more disadvantaged communities, because we know that they are less likely to engage with us. Along similar lines, my slide doesn't want to move ahead. Let's move it that way. Okay, along similar lines, resilience and social cohesion has been an important theme in success measures for post-disaster. So if there's any learning that we can learn from disasters around the world to apply to COVID, then this concept of community resilience has been quite key. It was initially came from the International Federation of Red Cross and Red Crescent around environmental disasters. But I think that these 5 areas here that the Red Cross propose as important for social resilience and social cohesion are probably pretty applicable to us as we think through our recovery from COVID, and worth thinking about. And finally, I've put the Build Back Better graphic on the final slide, because we have a real opportunity here to build on the assets that we have already in our society, but also build on some of the lessons that we've learned as a result of COVID, where we've seen some really positive changes in behaviour, some really positive changes in the way that we work and live, and some real engagement and enthusiasm for getting more engaged in community and society. So we have a real opportunity here, and I think I would really commend the Build Back Better model. Really has done, they've done quite a lot of work about how they think it could be applied to post-pandemic, and I think it's really worth us paying attention to that and digging into a bit more to see how we can apply that to our recovery planning across Berkshire. We're very lucky in that we have already a really strong group of people really thinking through how we're going to coordinate our recovery planning across Berkshire, and many of the concepts that I've talked about in this report are included. Really great to see, you know, strong voluntary and community services, green issues, mental health, inequalities really up there on the list, which is really good. But as we learn from Building Back Better and other disaster recovery experiences, it's clear that what's in our recovery plans is important, but how we do our recovery is going to be really important. So I'm going to finish there. I really hope that you found it useful, and I really hope that this, the intention of this report as a conversation starter, will achieve its aim, and that you'll be able to use it and refer to it as we continue our conversations about recovery across Berkshire. Thank you.
Thank you very much, Tessa, for that. Just to provide you some reassurance that these things don't just get lost. Last year's report you did, which was really interesting around employment, was it a matter of some discussions when we were looking at scoping out the joint health and wellbeing strategy for Berkshire West, and there's quite a lot of excitement about how we could apply some of those sort of things we're raising in our action plans, and I'm sure what you've got here as well, likewise. So thank you very much for that. I haven't got anybody indicating that they've got anything they want to ask, or I've got someone raising their hand, but it's in my list. It's
Hi, Councillor.
Andy Czerski, please.
Yeah, Andy Czerski, GP and Vice Chair of the board. Tessa, just like to say thank you very much. I think, as you say, it's a good conversation starter and a lot of thought-provoking elements in there. As the Chair has already mentioned, I think there's a lot of things there that could help feed into the joint health and wellbeing strategy that I know your team has already started on, has had to pause through COVID and is now reinvigorating again. And I'm sure they'll be adapting the strategy to the post-COVID response. And I think that's right. I don't think COVID is going away very quickly. The after effects are going to be long lasting. So I think it's very important that we take seriously everything that you've put into that report. There's lots in there. And I think various members of the board in their various roles will be hopefully taking that into all their organisations. And I think the strategy, which I know is, I was in one meeting was asking, well, what's the point of the strategy? I think it should be setting the scene for all organisations, whether in health, social care, adult care, urgent care, whatever part of the health and social care system. It should be what's, as you said, building back together should be the motto for the whole system. And if we can all work towards that together, then that should drive our strategy over the next 5 years and potentially beyond. Thank you.
Thank you, Andy. And I'd also like to add, I think this is some stuff to digest, but we, as a council, we're looking at developing a new corporate strategy, which can be quite a dry document, but we're trying to make much more less dry and much more exciting in terms of addressing actually the discussions we've already had, very much relating to a number of those issues that you've raised. So I think we need to digest some of that further when we're developing our plans. I've got Tony Jones has sort of made a comment. Do you want to say that in person? Tony, would you like to speak?
Well, only to say yes, thank you for a very interesting and thoughtful presentation. But as it happens, I've been scribbling down some things and almost reassured to hear that some of the things that you thought should be highlighted as priorities that we'll be coming on to next in terms of the adults, the Safeguarding Adults report, which, again, Chair, I don't want to jump too far ahead, but when my heart sinks when we see something that says Safeguarding Adults report 2018-19, and we're kind of midway, well, towards the end of 2020. But there are some things highlighted in that report that do relate to specifically the lack of access or the underrepresentation, particularly amongst the Asian community, to social care services. So, you know, I fully endorse what was said. You know, we need to seize the sad circumstances that we're in, but we need to seize the opportunity, if you like, now to do that looking in the mirror. So I'll certainly be picking that up later.
Great, thank you for that, Tony. That's helpful. Anybody else indicating any other? I can't see anybody, in which case I'd like to thank you again, Tessa, for that. Rest assured that I think you've, what's within your report is stuff that we're very much wanting to take on board, developing a number of different plans, a number of different areas. I mean, I will also rest. We have a meeting together of various members of this board, and I've had other discussions. And one of the things that's come out loud and clear across partners and community groups and across Reading has been very much a desire to really take really strong action, particularly around inequalities, around inequalities impacts we've seen particularly on the Black and Asian minority ethnic communities, and thing that people said over and again is now's the time really to be brave and to really just push forward on action, really quickly. So I think your document is particularly helpful and relevant and timely for that. So thank you very much. Thank you. I haven't seen anyone else indicating other than Sean Douglas. Really helpful document, thank you. So that's great. So let's move on to the next item, which is the Berkshire West Integrated Care Partnership System Recovery Approach. We've got Sam Burrows again. Sam, over to you.
Thank you very much. Yeah, thanks, Councillor. So quite a short presentation, this, in contrast to some of our previous items today, but what we lack in written detail, I'm very happy to make up in questions and verbal discussion afterwards. So I hope it's helpful. Firstly, apologies for the acronyms. I think we aspire to use as few acronyms as possible, and yet they still creep in across the board. So I will try my best to give long form versions of some of the initials you see in the slides, and like I said, happy to kind of drill into any of the detail which comes out following the end of it. So presentation covers a few kind of high level themes really. Firstly, an overview of our recovery approach in the Berkshire West system. The ICP is, as I'm sure most people on the call know, a partnership of 6 statutory organisations. So when I refer to the Berkshire West ICP, I refer to the Berkshire West CCG, who employ me, but also the Royal Berkshire Hospital, Berkshire Healthcare Foundation Trust, and the 3 local authorities in Berkshire West, of course, of which RBC is one of those. I'm also going to touch on what our objectives and principles are for this work, which really guide what we're doing and what we focus on, how we assess and evaluate the impact of the work that we're doing. And I wanted to really touch on as well how this fits in with the recovery work that's being driven nationally by NHS England, and how that translates into the work being done through the integrated care system at a Buckinghamshire, Oxfordshire and Berkshire West level, from here on affectionately known as Bob. So I'll just sort of get into the slides if that's okay. So in terms of our strategic approach, obviously it's around recovering through our response to the COVID-19 pandemic, most notably around the restoration of the full range of services that we are required to provide by law, and ensuring that where we are putting in place rapid transformation, that we're evaluating the effects of that transformation and embedding the things that work. I think it's probably quite clear now that in the period between March and May, a huge number of different modes of operating were trialed and implemented, and many of those things were actually very successful. I touched on some of those in my answer to Mr. Lake, particularly around the use of digital outpatient services. And really, we've got an obligation to, where those things are successful and working, to make sure that we are embedding them following a thorough period of evaluation. I also want to show how it fits in with our ICB governance, so how the 6 partners assure themselves collectively that the work that's being done is both right in its approach and effective in its implementation. And as I mentioned to you previously, I'll also show how it fits in with what's happening at a BOB level as well. So, Nikki, are you showing the slides up on the screen? I've given my verbal intro, but are you happy to hop to slide 3 and just share that with the rest of the members of the board?
I hadn't realised I needed to, so I will have to go and just find this presentation and get it up.
Okay. That's fine. That's fine. I'll keep talking, and then we'll see kind of where we land as you find the slides. So, in terms of the objectives overarching, so 5 really kind of key objectives that are meant to be mutually exclusive and focus on us achieving the best impact here. So 1 is around patient and population safety, so ensuring that our citizens and our residents have the confidence to access the health and care services they need, and that's our responsibility by both offering a high quality and a safe service itself, but also promoting this service to people and ensuring they know that it's operating and effective. Nikki, I'm on the 3rd slide, which is a sort of blue table, table 1. That's it, thank you. Number 2 is around stabilising our workforce, with a particular focus on retaining our key workers. Clearly there was a significant social and psychological shock which arose from having to respond to the pandemic. And we know, and I think that Tessa kind of really beautifully outlined this very eloquently in her presentation around the disproportionate impact of COVID on our colleagues and partners who come from Black, Asian or minority ethnic background. And we're doing a huge amount of work on that. This is both sort of operational and strategic. So I think what I've just sort of spoken about sounds quite strategic, but the reality is stabilising the workforce also means enabling people with a safe environment day to day to come into. It also means that when a member of their household, like a child at school or their partner, feels unwell, that they have access to quick, timely COVID testing to enable them to get back to work quickly and safely and to feel confident they can do so. So really a huge focus on the workforce, both on the sort of NHS clinical side and the social care side as well. Number 3 is an aspiration that we, as a minimum, achieve our previously delivered levels of access and performance of our core services. You'll have seen a fair amount of press attention on this, I think, around ensuring that patients can continue to access the full range of services, and when they do access them, that they aren't waiting for a significantly longer period than they previously would have done. I think this was the nexus of the question from Mr. Lake, and it was really well put and asked. We clearly have a moral obligation to ensure that people aren't waiting too long for services, particularly where there's a correlation between waiting time and clinical outcome. I think if I could just sort of, as a sidebar to this point, just say that really a big thank you to colleagues in the Royal Berkshire Hospital in Reading who have managed to essentially keep their full range of services open, even at the height of this pandemic earlier in the year. And as a result, the waiting time and waiting list position in Berkshire West and in Reading is significantly better than most other parts of the country. And that comes down to a really strong, I think, ethos and performance at the RBH. So I'd like to go on record and just thank them for their efforts in doing so. The 4th objective is something I touched on earlier, which is that actually where we've made a transformational gain, that we use that to take a broader approach to improving the overall well-being of the wider population, with a particular focus on a rising array of conditions, which we know have worsened because of COVID-19. They've worsened because of the social effects of a broad and restrictive lockdown policy. We know that as a result of that, there are a significant increase in anxiety and substance misuse, in hypertension, cardiovascular disease, renal conditions. These are really, really serious, big-hitting conditions. And we need to take a collective responsibility with our partners to address that range of challenges. And that also includes something else which Tessa touched on, which is a falling rate of childhood vaccination. These are things which we have to take a collective view on and a collective responsibility on. And that's one of the great strengths of working in a partnership, whether it's in the Berkshire West ICP or part of the Bob Integrated Care System. And the fifth objective is that we actually play our part as a public sector collectively as being a part of the wider economic recovery, which is not a space that we would traditionally play in as an organisation. That's something we would really sort of defer to others. But actually, the NHS, speaking on behalf of sort of my side of the fence, the NHS is the 5th largest employer in the world. We're the largest property owner in Europe. We clearly have a very, very important role to play in ensuring that the economic shock that we're feeling as a result of the COVID-19 pandemic can be mitigated as far as is possible through the work we do, either as an employer or as a contractor or as a prompt payer or buyer purchaser of services from both other public bodies and the private sector as well. So those are the 5 key objectives. Our main principles are on the adjacent half of the slide there, which you can see. So firstly, it's that actually the right scale for approaching this challenge is actually at a place-based. So, and by that I mean for us, that's at the Berkshire West kind of footprint. We know our business. We are a different geography to Buckinghamshire or a different geography to Oxfordshire. We've got a really, really strong local partnership here. And we want to work together to make sure we get the very, very greatest impact of that partnership, working under a broader kind of coalition with colleagues in other parts of Bob. Secondly, is that the principles need to be something which all our organisations have signed up to, and I'm very pleased to say that in Berkshire West, all 6 of our statutory organisations are fully signed up and aligned to the things you see on this slide here, which I think, again, is a really positive thing and speaks to the strength of our collaboration. Thirdly, that where we've made transformational gains and improvements by using a digital solution, that actually we retain that and we embed that, and that part of our approach to our future sustainability is that digital by default is a really strong part of that. And there are some really, really important arguments to hold in mind around the sort of digital deficit and digital poverty. I think it's often referred to as, we need to make sure that the full range of our population can still access the services they need to, but where people can use a digital or non-face-to-face solution, let's leverage and make the most of those opportunities. Fourthly, equity and fairness. We have always lived by this particular rule since we formed as an integrated care partnership. Decisions taken by single organisations should not be taken when they unfairly impact on partners. We're doing some really positive work at the moment, I think, collectively around hospital discharges and the interface between discharges and adult social care. And Shona, I know kind of you're on the board today. I'm sure kind of you'd speak positively about that process, hopefully, that as a partnership, we are working that through collectively so that the impact of working in a different way is shouldered collectively and isn't done in such a way as to unfairly impact on a particular individual partner. And finally, our final sort of 5th principle is that we need to be data driven. We need to use good evidence around population health data to ensure that we are understanding the inequalities and the unidentified needs that are existing within our communities. And COVID has, I'm sure, exacerbated some pre-existing inequalities across Berkshire West, and it's our job to ensure that we are using that data to both understand and put in place plans to tackle those. Can I have the next slide, please, Nikki? Thank you very much. So in Berkshire West, hopefully you're aware we've got a number of programme boards which are multilateral working groups of senior officers from all 6 of the organisations, and they come together to focus on a particular array of services. Some of them are sort of purely health focused, some of them are more around joint commissioning and the work we do together across the 6 of us. But those programme boards have gone through a process, particularly throughout the first quarter of the year when we were initially responding to the pandemic, to undertake an impact assessment around our approach to responding to COVID-19 and to develop a specific recovery plan in that sector. So, for example, our long-term conditions programme board has, as you'd expect, taken a really, really strong view on how we're going to respond to dealing with respiratory issues when dealing with a pandemic, which seems to be focused purely really on a respiratory outcome. And there's been some really, really good work coming from that. And we can talk a bit about the respiratory hubs that have been operating in Reading and in respiratory hubs that we've been operating in other parts of the patch as well. It's a really good example of how our programme boards have worked in a different way over this period. And we're trying to really live by the graphic you can see on this slide here. So first of all, in those programme boards, undertake that impact assessment to understand what are our kind of challenges, what's the new ways of working we need to undertake, can we do some sort of peer review or work with colleagues in public health or on our borders to understand any sort of learning from a wider geography, and do the benefits of those changes align with the objectives and the principles that we've just talked about on the previous slide. If they do, we move into a sort of recovery strategy. So ensuring that what we're putting in place meets our objectives. We're defining the areas which have the greatest and the most rapid benefit, and then we're collating that sort of overall and overarching impact as a total rather than just on a scheme by scheme basis, because this really is a very broad ranging recovery piece of work. And then as we move beyond that, we get into implementation, and the implementation is absolutely around putting in place something new which meets this new, very, very new and unprecedented challenge, but allows us to build out from there and not slip backwards. So, I mean, this is really kind of the way we've been working collectively over the last 6 months. Nikki, next one, please. So, oh, that slide didn't do what I was expecting it to do. Apologies. So clearly, as a result of that, what we have therefore done is to ensure, as I said, review the priorities, undertake the impact assessments, work towards implementing new schemes, new ways of delivering care. We're still very much in that process. We recognise that there's a need to do that in a way which is consistent with operating in a second wave of COVID, because we've now got a longer term aspiration to hold these kind of gains and improvements, whilst at the same time having to respond to a set of challenges which are going to feel very, very familiar and similar with what was felt back in March and April of this year. And the kind of key part of this, and I guess I keep harping on about it, is that we use our partnership to best effect to do so. So we're using our ICP programme boards, we're using our ICP clinical oversight group to test the robustness of our plans, and we are defining and setting up specific ICP working groups where there are particular changes which need to happen, which don't fit one of our pre-existing kind of ways of working. And again, I would probably use the example of our discharge to assess hospital discharge service. We've got a very effective working group of senior officers working collectively on a very shared and knotty challenge. Next one, please, Nikki. So in terms of governance, this is what the BOB governance looks like. So the BOB System Leaders Group is operating as a collective of chief executives of the statutory organisations in the BOB geography. They are holding the ring on the recovery board. There are a number of BOB groups focusing on 4 kind of key areas around elective planned care, mental health, primary care and cancer, with a number of cross-cutting, supporting, enabling groups, looking at improving how we use our estates. Clearly, estates has been a huge challenge when trying to operate a range of services with social distancing and other kind of challenges like that. Workforce I've spoken about already. Good data and analytics as well. I've kind of spoken about digital, using our digital solutions to implement these services and rolling that learning out amongst all of our organisations, and then being really, really strong on tracking the benefits of that, which we're doing at a place level and then feeding back up into the BOB Programme Management Office. And just that orange box at the bottom there, which I think links back to one of our objectives from a few slides ago, the contribution to the wider economic recovery. And for me, in my role, that's very much discharged through my link back to the local resilience forum at a Berkshire and at a Thames Valley level. So that's where we sort of tie those kind of bits together. Next one, please, Nikki. Thank you. And then in Berkshire West, this is kind of what it looks like for us. So I think the key kind of 3 groups to focus your attention on here are the 3 blue boxes in the middle of this slide. So the Integrated Care Partnership Leadership Group, which is comprised of chief executives, chairs, and elected members from the parts of our geography. The ICP Unified Executive, which is our chief execs, nominated director, and our directors of adult services coming together to focus on these topics, and then our delivery group, which is our kind of senior managers who are in the detail of delivery with this, supported by 3 very strong locality integration boards, which also have the opportunity to get into some more of the detail of it. And the program boards that I referenced earlier, you can see in green at the bottom of this slide, focusing on I think there's 11 there, focusing on 11 particular different either specialties or cohorts of our residents where we need to take that focus. Thanks, Nikki. Is that it? I think that might be the last slide.
I think it is.
So thank you. Probably spoke for a bit more than I was expecting there, so apologies. But I really hope that's helpful in terms of an overview of both what we're trying to achieve through objectives and principles, and how we're working collectively to try and achieve that, either at a Berkshire West place level or our interface back up through Bob at the ICS. I hope that's helpful, and I'm really, really happy to take any questions that you might have as well.
Thank you. Thank you, Sam. I haven't got anyone indicating. I've got Shona Douglas who wants to make some comments. Shona.
Hi, thanks ever so much.
Hi, Shona.
Councillor Hoskin, and thanks, Sam. And I suppose I just wanted to reiterate really the value of working across the West Berkshire footprint, and the the kind of relationships that we're developing, which is actually to benefit all residents, and particularly to utilise our resources in a much more creative way, given that we have to kind of manage those in a tightly managed way at the moment. It's really important that we share that and don't duplicate. And I suppose there's 2 bits that I wanted to kind of talk about. One is around the discharge from hospital and the importance of people being back in the community at home when as quickly as they possibly can be, and the work that we've done around Reading, particularly at this particularly difficult time. And I think that one of the projects that I suppose I want to flag, which was a joint project, was the creation, which is well known about the Holiday Inn and the support we had in using that as a step down facility, and that certainly we would look to that as an option in the future if we were in difficulties again as we head into the winter around the COVID period. So I think we've kind of demonstrated, and it has been seen as a model of good practice in the country. Unfortunately, I keep getting lots of phone calls from people asking, what's your spec? How did you do it? So we're trying to do some hour-long sort of webinars to help other people understand that actually you can make it happen if you really want to, and that was with partners from BHFT, the Berkshire Health Foundation Trust, and the CCG, so and other partners, voluntary partners as well. And I think the other bit of work, just to kind of clarify, is about how we commission services in a more joined up way. And we know that presents challenges when we're in different unitaries, but we are working through some of those in order to get the value of the integrated care partnership, and to make sure that we are purchasing the right services for people that are local. So I just felt it was kind of wanted to endorse, Sam, some of the good work and the relationships we're developing, which is for the benefit of the residents in these hard, challenging times.
Thank you so much, Shona.
Thank you, Shona. I've got Mandeep Baines of Health Watch indicating. Mandeep.
Thank you, Chair, and thank you, Sam. That was so informative, and there is clearly an extensive amount of work going on that we don't see. I guess I just have a general comment. Things have changed so rapidly with services having to reduce, come back, move around. One of the important things, especially when it comes to building confidence in our local community to attend services, is communication. And I'm really sorry, I cannot say this enough, because communicating about how services are operating, and that is not just writing to the patients who are directly impacted by that service during that month about a delayed appointment. It's where services are moving, ensuring that they know enough about how they're being run, that the quality is being maintained. I think, you know, as a leader across the ICP, encouraging our providers, etc., and yourselves to communicate more with the public, really on their level about the detail of services, will certainly help build confidence in using those services more.
Yeah, could I just sort of come back on that, Mandy? Because obviously I agree with everything you've said there wholeheartedly. And there's three things that I kind of have to worry about and work really closely with colleagues, particularly in the RBH actually on this. One is around that piece of engagement you've described, absolutely rightly, around communicating what we're changing and why. I think we can do better at that. I think we've kind of made a lot of progress in that regard over the last year or so, but we can still do more. And actually, we probably don't avail ourselves the full range of media that we've got available to us, either formally or informally. And actually, it's a point I was making to my staff this morning in my sort of weekly blog. I referenced how many people the NHS employs globally. Well, even in Berkshire, we employ sort of well over 20,000 people, and all of us individually are actually ambassadors for the service, and we're trusted voices because people know that we work for the NHS and we're employed by them. So actually, when we see things on social media or where friends and family have got questions about what's happening, what's open, what's different, we should have the confidence to answer those and actually be sort of, you know, I feel like we're playing a kind of really important part in either myth busting or just informing people and letting them know what we're changing. So that's one, and I completely agree with you. Now, I'm going to take that back actually and talk to Victoria next week, who's our shared director of communication. So thank you for raising it. Secondly is around the impact of changes from an equalities perspective. And I almost mean that with a small e, so not just focusing on those sort of protected characteristics as defined by equalities legislation, but thinking more broadly as a population and the associated parts that come with that. So are we confident, for example, when we change or move a service to a different particular location, have we thought about everything from a public transport perspective? Do we know, are we confident that people can get to a different site or facility? So we do that work, but things are moving very rapidly and we need to really make sure we're holding ourselves to account when we're doing so. And thirdly, and perhaps most importantly, is around evaluation. So much has changed so quickly to enable us to respond to the demands of this global pandemic. And I really honestly believe for the most part it's changed for the better, and we're able to provide a better and more resilient and more sustainable service to people. But there will be people it doesn't work for, and we need to really make sure we're reaching out and hearing from those people to ensure we've got really strong and sufficient mitigating actions in place. And one of the things that I'm really sort of looking forward to, and I hope that Mummy mentioned this Mandy, is yourself and colleagues are coming to our Unified Executive in November to report back on the really extensive survey you've done with hundreds of people in the geography to find out what their experiences were of accessing health and care services during the pandemic. And that's going to be brilliant for us as executives because we can take that learning and adapt what we're providing accordingly. So sorry, the answer was longer than the question, which probably isn't the way it should be, but it's such an important point that you raised. I just want to give confidence to you and the other members of the board that we take that really, really seriously.
Thank you, Sam. What Mandy asked kind of was I was going to ask as well around that communication involvement. I haven't got anyone else indicating. Thank you very much for that. It was really informative. The one point I would make around communication, I think one of the things that we're all going to have to do around, the partners, also be quite honest and clear with residents, with people around the financial challenges. So I know that before lockdown, the Berkshire SCCG had a substantial, I think a budgetary challenge in terms of a budget gap. I think it's important that we're always honest about that, and I think councils perhaps are quite good at that. It's slightly easier for us because we're not quite so closely connected to central government. But I think that might be quite important with some of the message from the national government around, how well they've funded the NHS. I think it might be quite important to be clear, actually, that there's some quite difficult decisions to be made locally, and to be very honest and upfront with people in order to maintain that trust that we're talking about.
I think that's right. So the underlying structural financial challenge hasn't gone away, as you wouldn't expect it to. We have been really well funded over the first half of the year, and all the money that we have required to meet this challenge, we've been able to access additional funding to do so. But in future years, we will have to come back and have a look at the structural financial challenge that we had prior to COVID, and we still got to find things to do to address it. And it's really important that our local people are a part of that challenge, I think. And I agree with you, Councillor, we've got to be really transparent about it.
Thank you, Sam. So unless anyone else is indicating, we'll move on. I was told by Nikki that the we're having an IT work for the council over the weekend, and it shuts down at 5 o'clock. So I think always like to be finished before that anyway, one of these health and wellbeing boards, but it's a little bit different online. But that hopefully gives a little bit of focus that we need to proceed at pace in order to be finished by then, if not to be thrown out of the system by IT. So let's move on then swiftly to the annual influenza report. Is it David Monday I've got on the
yes,
report?
Chair.
Can I lead off, David? Thank you.
Yeah, thank you. So I will keep this brief, conscious of time. So this report does two things. It looks at last year's flu vaccination campaign, and it looks forward to the flu season that is kind of already upon us. And what I'll do is talk firstly about last year, then about this coming year, and on both make very brief comment about the virus itself and how it behaved, or how we think it might behave, and about the vaccine programme itself. So 1920 was, I have to say, a fairly mild flu season, which is good news. It was also a fairly early flu season, so the peak week, so a phrase we've become increasingly used to using since COVID, was actually kind of really around Christmas time, which is early when you look at what's usual for the flu season. The strain that circulated was actually very well matched with the vaccine itself, and we didn't see a big impact in terms of morbidity or mortality from flu over the last year. And the report does explain through where we did see some outbreaks, etc. But it wasn't an impactful flu season. In terms of how uptake of the vaccine worked last year, I'm pleased to report we had good uptake in Reading. And if primarily we kind of measure how we're done in the year before, so the flu season before, so 18-19 compared to 19-20, we did see an increase in uptake of the vaccine in those who are vaccinated in primary care, so over 65s, those who are at risk, so with people with long-term conditions, pregnant women, and 2- and 3-year-olds, to give not, those aren't all the eligible groups, but to give some of the headlines. And we saw an increase in uptake in all of those groups. Within pharmacies, we saw so pharmacies can vaccinate any kind of adults who are eligible, and we saw a significant increase in the number of vaccines that were delivered in pharmacy as well. We saw a marginal decline, just by 0.5 percentage point, in the uptake within the school immunisation programme last year. So that was the only marker that went, if you like, in the wrong direction. There is still a bit of work to be done. We're not necessarily at the national ambition in each of those areas, but I'll make comment on that and also on the school programme in a second, just regarding the 2021 programme. But that's really the summary of 1920, and undoubtedly a successful flu vaccination campaign is very much a multi-agency approach. So we're very much involved from the local authority side. The service is commissioned and delivered by NHS colleagues, but others around the table have a significant role to play as well in the promotion of the vaccine to those who need it. So thinking about this flu year, so the 2021 flu season, clearly we are concerned about the risk of a second wave of COVID and flu co-circulating. And there is evidence now that follow kind of what you would expect, I guess, that people infected with both respiratory viruses simultaneously have a higher mortality risk. I think that's probably a statement of the obvious, but we do know that risk is real. On the positive side, there is some evidence from the Southern Hemisphere, who obviously have their flu season at a different point to us, so looking at learning for flu co-circulating with COVID from the Southern Hemisphere, that probably with the social distancing in place because of COVID, there's been lower transmission rates of flu, and they've not had a significant flu season to date. So I'm touching wood as I say that, but there could be something that's helpful for us in terms of the current situation and flu for this coming winter. So on the vaccine kind of delivery of the vaccine program itself, clearly the name of the game this year is about delivering vaccine in a COVID secure way. And whether it's in primary care, whether it's in pharmacy, whether it's our school nurses, whether it's midwives providing vaccine in antenatal clinics, all of that is being planned and thought through to be delivered in COVID secure ways. I said I'd come back to the school programme. So one of the innovations this year is that where children have not had the nasal spray vaccine for flu, which is the standard vaccine given, because of the porcine element, and we know that causes some challenges for the Muslim community, there is the option for children instead to get the injectable version of the vaccine, which doesn't have that porcine element. So we're hopeful that that will widen access this year. As I think it's been quite well reported in the media, eligibility for the flu vaccine this year is being widened. So we're going up to year 7 in school this year. We're ensuring that everyone on the shielded list, but crucially their household contacts, are also all being offered the vaccine, as well as personal assistants and those employed through the personal budget scheme within the social care field are also vaccinated. And the aim is to get 75% of every eligible group vaccinated this year. There is also the aim later in the flu season to extend to 50 to 64-year-olds as well. And further announcements about that will be made nationally. As an employer, Reading Borough Council is taking the step to offer all its staff flu vaccination for those who aren't just simply eligible through the NHS scheme, to ensure we get wide coverage across the piece. So that's really the whistle stop that I wanted to say. The details in the report for people to kind of read at leisure. So the board's asked to kind of to agree and endorse that multi-agency approach that I explained. We want all groups to take forward as they are their kind of actions and responsibilities regarding the national flu plan. We all need to be flu champions, promoting it in the various avenues and areas that we can. And of course, we should all lead by example and get vaccinated where we're eligible as well. So I'm deliberately quick, but hope that's helpful and happy to answer questions.
Thank you, David. That was helpful. In fact, you did. You actually answered one of my questions at the very end. Any questions or any points anybody wants to raise? That's your chance. Mandy, want to ask that yourself, or shall I just? So Mandy says, "Hi, hang on, you're going to speak." Mandy, please go ahead.
Just yeah, the plan sounds really good. Just wondered if you had any idea of the uptake so far, or are we too early in the season?
Yes, slightly too early to give meaningful comment. We know that when you compare pharmacy activity this time last year to where we are now, we've delivered more in pharmacy this year already. So that's an indication that there is good kind of demand out there, which is what we want. But in terms of having the kind of denominator data of eligible groups and then measuring uptake kind of against that to give a true picture, it's a bit early to say, but certainly a good indication that people are kind of taking heed of the message and getting vaccinated, and happy to update the board as that data becomes kind of more readily available.
Thank you, David. And yeah, I think hopefully that side from the pharmacy suggests that people are really taking this seriously, but obviously fully endorse the recommendations. I've got Andy Chersky, please. Andy.
Yeah, just from the front line in GP practice, our last Saturday flu clinic, we used up all our vaccine for all the over 65s that were invited, and we're actually having to ration our under 65 for the risk groups to make sure all those that have had an invitation to a Saturday clinic come in and have a flu vaccine that's available. So we're targeting our highest risk first, and yeah, we're going to run out, so we may have to go to extra stocks for if there's a further campaign to get other people, such as the 50 to 64s. We won't have any of those. We'll have to get extra stocks in if the supplies allow. Thank you.
Thank you, Andy. So sort of positive in terms of it looks like people are really getting the message, but obviously the worries around the supply of the vaccine. But let's hope that doesn't prove to be a problem. Anyone else? In which case, thank you very much, David. That was really helpful. And obviously, hopefully we're all endorsing the recommendations around that plan, unless I hear otherwise. Right. So the next item is, and I think Mr. Andy Fitton has made himself visible, is the update on the mental health crisis review and building a primary care mental health offer. So, Andy, I haven't got the list of who's. You made yourself visible. I do believe you are going to start us off on this. Andy, over to you.
Try anyway. Thank you, Austin. Thank you, board. Purpose of the report today is to give you an update on where we are with two transformational priorities that was actually scheduled to come to the board. I think it was April or May. I can't exactly remember. So I think it's just important to bring this back to you at the most convenient and earliest possibility. And Sam's already described, and I was going to say that this work has been under the sponsorship of our Mental Health and Learning Disability Programme Board, which is in our ICP, which Sam has really well described earlier in the meeting. So effectively, we've got two bits of work to describe progress on. So in terms of the crisis review, that's been the significant piece of work and a very comprehensive piece of work of 8 or 9 months leading up to April 2020. There was significant co-production across section of agencies and staff, and importantly, people and carers of people with mental health needs in the production of looking at what do we need to do to improve the response when people have a mental health crisis. And when we're talking here, we're talking adults primarily, but we also did look at children and young people. We were looking because actually many of you may already have had presentations on the long-term plan from the NHS, the 10-year long-term plan. Mental health is a significant part of that long-term plan, and improving our NHS and partner response to mental health crisis is absolutely fundamental to that. What we want to do is to make sure that we have good access to the crisis support that people need when they need it. Make sure that there is continues to be an all-age mental health liaison service within our emergency department at RBH. It meets a particular standard called Core 24. We want to make sure that there is access to an all-age 24/7 support that will be on the phone, primarily through NHS 111. We want to look at whether we can get an alternative to crisis provision. There's examples of things like sanctuaries or crisis cafes around the country. That we look to augment eventually the mental health response at an emergency point with need for a sort of statutory ambulance services. And then thinking about how then we can link ultimately to trying to reduce the numbers and getting the appropriate numbers through our urgent and emergency front doors. So talked a little bit about in the report about our process, what we've done and you can see that we have done significant work with both our partners and staff and with our people that use the services. I'll come on to the 14 recommendations, and they're broken into themes. So there's a table at 2.3 in the report that shows all those recommendations. I think the first point very much is around having a single point of access for people that is consistent and is all age and available 24/7. There's been, you can see there's quite a number of recommendations there, and I'll come on to the improvements already that we've been able to make since April. So that's really encouraging. The second one is about having an alternative to crisis provision, and in particular we have recommended having one set up as a starting point to be based in Reading, and then to look to see whether there's a case for having something set up in Woking, West Berkshire. Although it would be based in Reading, it would be open to anybody that is a resident of the 3 local authorities. And to build on the successful work of our street triage service. I'll talk a little bit more as a second sort of piece of work around the development of a primary care mental health pathway that sits to prevent, hopefully, or pick up people as they move through a sort of escalation, so we kind of head them off at the pass, as it were. Looking at how we can strengthen that with some voluntary sector and peer support, and then thinking of the last bits about our communication, workforce development, and making sure there's good governance. In terms of going forward, so these recommendations went through our board in April, and we were due to bring it to you as a board not long after that. So we've made some progress already that I've highlighted, and there's a couple here that I think are really really good and worth noting. First of all, we have got our crisis line now set up. It's 24/7, and it is on the back of the work that's already in place around our home treatment team, and it's trying to free up that home treatment team to do less work on the phone but more out in the community. Between April and August already, we've had 1,400 calls into that service, of 600 odd were from Reading people themselves. We've got a professionals line established in that, which actually we need to do some work on trying to make sure that's used, particularly by our ambulance and police staff. So that's something that we're working on. So we're really pleased about that, and that already, due to COVID, actually has meant that we've accelerated the movement to make sure that's linked nationally into the NHS 111 service. So you can either call NHS 111 and they will direct you if you have a mental health episode onto this mental health professionals crisis line. This crisis line that's staffed by mental health professionals. Or you can call the crisis line direct, because the crisis line and the crisis numbers that existed for a long time, it's just better staffed now, and a lot of people that are in our community mental health teams already do use that service. I think the other thing that we wanted to talk about is that we have got approval now to start to go out to procurement and to commission a crisis cafe, which we're going to call Breathing Space. I said it's going to be based in Reading somewhere. We think that's partly because of the excellent transport routes in and out of Reading for people across Wokingham and even into West Berkshire. I think we're going to need to talk about West Berkshire, the sort of the communities that are further out from Newbury, because actually they're less well sort of able to get into Reading, so that will come in. But this is where maybe working in the regional BOB context will come to in our favour, working with colleagues in Oxfordshire and nearer to Swindon, that it may be more appropriate for those people to be accessing crisis support over the boundary there, and people in South Oxfordshire coming to Reading. So that's where we can start to really benefit from working in a new regional position. So the last thing I was just going to touch on, Chair, was the other piece of work, which is building a primary care mental health offer. So effectively, this is about trying to improve both the quality and accessibility of mental health support to our population that are presenting and coming through our primary care, our GP practices. That's the first thing. It's about driving up recovery rates. It's about trying to improve people's self-care, so trying to help them find local solutions long term. So sort of trying to decrease that reliance on constant medical input, trying to understand the flow and trying to decrease and getting the right demand into our secondary and acute care. And so also recognising that our people with serious or significant mental illness do need physical health checks on a regular basis. It's part of the health inequalities agenda that we need to focus on. So we've done some work today on, again, a very similar process to the crisis care, where we've co-produced this with colleagues from local authorities and health. And we've also done a lot of work with patient groups across our GP surgeries, and talked also to people like the Reading Recovery College, who obviously have access to a lot of people that have needs that would fall into this category. We've drawn particularly on a model coming out of Cambridge and Peterborough called PRISM, which I've put the link in there. And I think that's been held up as almost like a good practice model that we'd like to try and follow. We've got a model ready for discussion, and then unfortunately COVID meant that we had to be patient and wait to re-engage back about this subject now. And actually the timing couldn't be better in some respects, because we've just had the national invite to put forward a proposal to try and get hold of some transformation money that would give us a 3-year injection of money that needs to be matched by health to set this service up. And what we're looking for is a service that has both clinical and non-clinical opportunities for people to access both an emotional well-being offer as much as a clinical mental health approach, knowing that the two have to go together, that we would want to build this around our primary care network model, and we're looking to try and find a pilot site when the money first gets released to test and to make sure that we've got proof of concept before we do the full rollout. So we're excited that it's going to give us a real opportunity in the next few weeks and months to get this actually going from an initial discussion phase into actual real plans. It's been a long time coming, and people, colleagues, know we've been probably talking about this for a year, but it feels like we're on the edge of now moving into an operational reality. And although sometimes things do take a long time, I think it's worth sometimes doing that so that people feel like they know what's happening and that we're not just rushing things to a solution, that it does feel like we're doing that connected with our partners and with people that would want to use the services. Thank you.
Thank you, Andy. I think you might have a future in politics with the spin on, well, sometimes it's better for things to come more slowly, but I like to let that in. Thank you very much for that presentation. It is really good to see these things really moving forward, because I've been talking about them for some time. Have I got anybody indicating any questions? I haven't got anyone indicating at the moment. I've got Andy Cichersky. Andy.
Yes, Andy, thank you for that report. I mean, obviously, working in primary care, it's of great interest to me that mental health workers will be coming out, hopefully, to work out of our GP practices. It's a long time, going back to maybe my early days of working as a GP, which is a long time ago now, that we used to have mental health workers actually working from the practices, and then everything got taken away, things more centralised in a different way of working. I think getting healthcare out into the community where the patients are and working around the neighbourhoods and primary care networks is probably the way forward. There's different needs in different parts of the patch. As we know, central Reading mental health needs are slightly different from those of maybe leafy Caversham. But we have our own problems with older demographic and maybe more dementia. So all of those things are going to be very helpful, and we look forward to when this comes to fruition. Thank you.
Thank you, Andy, and yeah, I completely agree. So I haven't seen anyone else indicate, in which case thank you very much, Andy, for bringing this. This is some of the stuff we've been looking forward to, and I suppose what will be interesting in the coming months and years is whether there's the concerns around growing levels of mental ill health, pressures on people, emotional well-being, and how the system can cope with that in terms of resources available and capacity will be something that will be really important to see as well. But I think that's really positive direction in terms of what we're trying to deliver, and really excited to hear about the crisis cafe as well. I think that's something that people have been saying for a long time. We really want here in Reading, so looking forward to that as well. So. Thank you. It's always good to have you at the board, Andy.
Good to see you, Councillor. Thank you.
Thanks. Right, I've lost my agenda. I must have put it somewhere. What have we got next? Here it is. So the next item is, well, it's the Health Watch annual report. Mandy Baines, please. Over to you.
Thanks, Chair. This year we were given permission by Health Watch England to produce a summarised version of an annual report, given current pressures amongst all services and all systems, including Health Watches. So this is a short presentation on a short report, but much of it feels very much about what we're going through now, and it feels like the whole year was actually about the last quarter and what changed and developed. So I really just wanted to take the opportunity to highlight 4 pieces of work we did last year, which I think are important and relevant to services as they develop now, impacted by COVID. So last year we spent a significant amount of the year looking at engaging our local community in the NHS long-term plan. And the long-term plan was about how health services should work for local people. So there was a lot that came out in that piece of work, but one significant thing that came out was people's experiences of mental health services. So most feedback we received about the long-term plan really focused on mental health services, and I think all of that learning we still share with programme boards because it's so significant moving forward. So that was a big part of our work over the last year. We then had 3 smaller programmes, which again are quite significant. So we ran a project called Log On to Health, which was working with local women from BME communities, helping them to be able to log on to GP services. So introducing the app, showing them how it worked. And actually that piece of work really empowered them to take control of their health and their family's health. And again, more important than ever, that we take up opportunities like that in this current climate. The other 2 pieces of work, we did a survey of young people's, maybe student health and well-being. So we worked with students from Reading College and the University of Reading, asking them about their experiences. That report is soon to be published, but a significant and the thing that most concerned students was mental well-being and where they could access support. And again, given our current times, that's still pertinent and significant today, if not more than ever. And the final piece of work, we always go in and out of GP surgery, especially when taken place, to see how services are continuing for local residents. And what we heard last year of concern was access via the telephone. And I think all of those things across those pieces of work have really helped us in terms of put forward local voices going forward, exactly as we've heard today, as how services shape and develop.
Mandy, you've really broken
and
up.
finally, changing all of them and joining the community subscriptions. Is that better?
Up, you can't really hear. You might want to switch off your camera, and we might be able to hear you better.
Is that better? Any better? Okay, I hope that's a little bit better. But really, I was just saying that we ended the year with the prescription delivery service as part of the One Reading Hub. And that enabled us to actually support our local community in the way that they had been supporting us all these years. And we delivered over 1,000 prescriptions in the last month. And I just wanted to say none of that would have been possible without the support and leadership of our board and trustees, our amazing staff team, those volunteers that stepped forward who were delivering, I don't know how many prescriptions a day from all sorts of backgrounds, and also our health partners who really supported and got behind us to make that happen. Without all of them, none of this work would have been possible. And so I really wanted to say to all our teams, thank you for last year and all our partners, but especially thank you for enabling us to be able to support our local community when they needed it the most.
Great, thank you, Mandy, for that, and very sort of a concise report, a really interesting document that you've provided. Anyone, any questions, any points they wish to make? Missed anyone that's indicated. I've got Andy Czerski, please, Andy.
Yeah, I'm just going to
Yeah, sorry, I was about to ask. I'm not sure if it was me or Andy. Unfortunately, we lost you, Andy. With only 2 people on there, it's impossible to know whether I was frozen out or if it was Andy. It looks like it was Andy. Do you want to?
Yeah, sorry about that. I think I just got kicked out. I was just going to say that it was one of my ex-GP partners who's on the front page of the report. So very proud of her efforts during the COVID crisis and her response helping with prescriptions. So and all the volunteers that Health Watch helped to coordinate. I think that was a fantastic effort. And yes, just thank you, Mandeep, for this quick summary. All of those things are very important reports and pieces of work, and very valuable in supporting all the services that you go into to help drive improvements, especially in GP, the enter and views. We always take those very seriously and try and use those to improve our services. Thank you.
Thank you, Andy. That's anyone else? In which case, Mandy, I'd like just to echo that. Thank you very much for the report. It's been quite a year, and I think this is a really good report here. I think it's also just sort of personally, thank you for what Health Watch has done. But actually, in the coming months and years, I guess the role is going to be more important than ever. And I know that we sometimes have difficulty in trying to fund them. With the council finances under such pressure, we've had some difficulty in finding the resource that we'd like to provide in order to fund such an important service. But just like to thank you and the team for what's been done over the past year and the report that you've given. Thank you. Thank you, Mandeep. In which case we'll move on to the safeguarding adults report. As Tony Jones said, it is from 1819. Who's actually going to be presenting this?
John's going to present.
Myself, Chair.
Okay, John, thank you. Shona, you're on.
Okay, thanks, Chair. So sorry, I think I froze there for a minute as well. I wasn't sure quite who was frozen. So thank you for this. I'm going to try and be brief, and I suppose just in terms of pretext, really, I think this report is one that went to Policy Committee during COVID, and I think obviously it needed to be published by the Safeguarding Adults Board, West Berkshire Board, so it's coming here retrospectively for information. I'm conscious there's a lot of information in here. No way I can go through that in our 25 minutes or less, so I will keep it very brief, and I know that there's a couple of questions probably coming in. I suppose what I'd just like to highlight a couple of things while I've got the audience, really. So I think firstly, just to say there are 2 reports here. So one is the West of Berkshire annual report, which highlights the work that's been carried out across the multi-agency partnerships, ourselves, West Berkshire and Wokingham. And then there's the Reading specific report. And as the Chair said, it's for 2018-19. What came about really in terms of highlights that year? So there was a 37% reduction in the number of concerns when compared to the previous year. And that sounds quite alarming when you look at it, but it's actually a change in practice, which isn't actually a good thing, where a number of safeguarding concerns were not meeting the thresholds, but still getting recorded as safeguarding concerns. So what we've done in Reading over the last 18 months is we have a programme called Conversation Counts. So we have an advice and wellbeing hub at our front door. And we have a 3 conversation model, which is nationally recognised in social care, but one that we've kind of put our own taint on. But the 3 conversations are, the first one is to listen and connect to people. Second one is to work intensively with those people if they're in a crisis. And the third one is really about actually how do you build a good life going forward with someone who may need that little bit more care. So 3 distinct conversations, and we've been bringing that into our making safeguarding a personal approach. So having quite in-depth conversations with people up front, having a really quality conversation up front, and that meant that we could reduce the number of concerns, but the actual number of inquiries stayed the same. So when it was real safeguarding, it went down that route, and a Section 42 inquiry took place. So that was, I think, a positive change in practice. We've also got a safeguarding team who now oversee all safeguarding activity. So the safeguarding activity comes into that team and it's signed off by that team at the end. So that, in terms of sort of transparency and centralisation, that's really something that we're very pleased to see. I suppose what I'd like to just maybe pull out a couple of data areas. So this is where you have to do some quite intense scrolling if you've got the papers with you. I'm going to go down to, I think it's 176. So it's quite a way down. We're getting into the data. I just want to highlight a couple of things here, conscious of time. So overall, there was an increase in referrals from health partners, which I thought was positive. I think that went up from 137 to 176 in the year on year. We certainly had an increase from mental health and also from secondary care. So quite a substantial increase in referrals from those partners, which is a good thing. And I think looking at the age demographic as well, so 58% of our safeguarding inquiries were for people over 65. So again, that cohort 65 onwards is our biggest area in terms of safeguarding vulnerable adults. In terms of the Section 42 inquiries, the gender split, that increased again year on year. So we finished the year with 57% of the inquiries being females as opposed to males. And then in terms of the type of inquiries, that was fairly steady. Neglect and acts of omission was 38%, psychological abuse 21%, physical 20%, and financial 22%. They were broadly in line with the previous year. And then one that I was very, very positive about was where actually the safeguarding episode had been closed and the risk removed or reduced for that individual was at 73%, and that's compared to 38% in 2017-18. So that was a substantial uplift, and the other was a 20% where no further action was taken. But that showed that we were removing more risk or reducing more risk for vulnerable people. So that's just a very brief canter through some of those stats. I think overall, the journey in Reading is to have excellent safeguarding, to empower people and uphold their inherent dignity and human rights. We want to protect people and prevent them from further abuse. And I guess our partnerships are really key in making that happen. So I'm happy to take any questions. Thank you, Chair.
Thank you, John, for that. I've got Tony Jones. I'd like to say something.
Well, yes, thank you. Just to reiterate, I suppose, it is difficult, isn't it, to receive a report, which is the annual report covering the period 18-19, and we're 18 months on from that. And I'm going to fall into the same trap deliberately that John has, which is referring to the report, but then talking about what we're doing now and what we want to do in the future. And just to add, I was going to mention the fall in stats and so on, but John has ably covered those. One further area, conscious of the time, that's on page 178. Again, the Section 42 inquiries, but as they relate to the breakdown between white, mixed, Asian, British, Black, and so on. I mean, I think in this era of Black Lives Matters, we can't receive a report like this and not make specific reference to the disparity in terms of the lack of engagement or the underrepresentation of engagement, let me say, among some parts of our population. So with that in mind, I've already started an informal conversation with community leaders in Reading, and it would be my hope that we can firm up on some of that work between now and early in the new year with community leaders, so that we can discuss with them how they think that we can perhaps better engage in a culturally sympathetic and effective way, and with other stakeholders and partners, because we do really need to close that gap. As I say, that's the figure 18 months ago. I'd hope that figure has closed since, but I think we need to redouble our efforts. And as Tessa said earlier on, we need to look in the mirror. And if we look in the mirror and like what we see, as I do every morning, then everything is fine. But if we look in the mirror and perhaps think there are a few blemishes that need attention, then I think we're under obligation to do that too.
Thank you, Tony, and that's really good to hear that you're taking that on and focusing on that. Mandy.
Thank you. Just following on from what Councillor Jones has just said, one of the things, important ways we can hear the voices of vulnerable people is the use of advocacy. And I noted in the partnership board, they made reference to advocacy, but I think in a future local report, I'd like to see the take up of advocacy in terms of safeguarding referrals. It's such a big part of making safeguarding personal to ensure the individual's voice is being heard where they cannot articulate it themselves, and that they're fully involved in such an important and delicate process. So for me, I think it's great the way you're handling things, but we need to know more about how local people are involved in these processes. And if we want them fully involved, we need to make sure they're getting the right levels of advocacy support.
Thank you. Do you want to respond, John?
Yeah, I mean, on both those points, I think Councillor Jones is absolutely right. I think the Black Lives Matter movement, as I read an article where I think it was based in London, but 70% of the workforce is from adult social care. So we are a diverse population in Reading. We also have a diverse workforce, but there's something that's maybe not happening in terms of that the statistics don't lie, do they? Asian British people are less likely to come forward with a safeguarding concern or inquiry. So there's work to do within that board, and I think that sits within the priority 2 in the action plan, which is around breaking down barriers across agencies and promoting new approaches. So clearly there's a lot more work to do there. And then Mandeep, again, a very good point. We've discussed advocacy, I think, over the last year, and how we can increase that and how we can, hear that person's voice. Making safeguarding personal has been around for a few years, but we still have to absolutely nail it, and we need to have more of those voices in the assessments, more of those voices in the outcomes. So, yeah, absolutely take that on board, and we'll look to put that in a future report. So, thank you.
Thank you, John. Anybody else? In which case, with the IT guillotine fast approaching, thank you very much, John. That's really that is helpful, and some also be interested in those 2 items that we discussed, how that progresses, and look forward to the next safeguarding report, which won't be too long off. So thank you very much. Right, health and wellbeing dashboard. David, you've presented yourself, so you're going to do this?
Yep. This is me again. This is me again, Chair, and I will be swift in the interest of time. So this report does 2 things. It's updating the board on the indicators that we have selected to measure progress against our current health and wellbeing strategy, and also to just update on actions within the action plan to take forward that strategy for the 8 priority areas that it contains. So before I just come on to highlight a couple of points on that, just wanted to note to the board, as I'm sure board members are aware, we're in the process of developing a new joint health and wellbeing strategy, and that will be ready in the coming calendar year for the board to review. And we're about to launch the public engagement phase of the development of that strategy. The plan is for that to be a 3-month process, and for it to be as far-reaching as we can. Obviously, the way that we do public engagement right now is different to how it would normally be because of issues around COVID. However, there is plans afoot to ensure that that public engagement reaches our ethnic minority groups, our young people, and to ensure that we do wide consultation. And I know that Healthwatch and the voluntary sector are very much engaged in that, in how we do that public engagement work. But just wanted to kind of note that. But what this report does is just update on where we're at with the existing strategy. So there's a range of indicators that we've selected to measure our progress against the strategy. I'll just draw out a couple that have been updated since the last board meeting in March. What happens with these indicators is some are only updated annually, so there's not a change to report at this point. And it's worth noting that most of these indicators, not all, but most of them, relate to data pre-COVID. Because of some of the data cleaning and reporting processes, it doesn't always come through in a immediately timely way. So some of what we're presenting will, of course, in reality have changed in light of COVID in the more recent months. So the couple of things I just wanted to draw the board's attention to within priority 1, which is about healthy lifestyle choices, we've seen that overall we meet our target for adults who are overweight or obese, so keeping that number low, although there has been a slight deterioration, but we still can meet the target. We haven't got the same story with adults who are physically active, and that's an area that we need to be addressing. And Tessa presented before what's happened in lockdown in terms of active travel, and there's something about how we build on that and also how our services adapt to ensure that we're supporting physical activity. Smoking prevents in Reading a bit of a mixed picture. So overall, the update shows us prevalence is lower, but it is higher when you break it down and look simply at those of routine and manual worker occupation. And again, as our smoking cessation service has adapted to working in COVID, one of the things is to ensure that we can continue to deliver an effective offer for everyone in the borough so that we can reverse that inequality. In terms of our NHS health check performance, that has improved, although we still need to do a bit more work to get to the target level that we had set for it. And again, post-COVID, that's something that, well, as we recover from the first wave of COVID, I should say, really, that's something we want to take forward in terms of how we best prioritise the NHS health check programme to those who stand to benefit the most from having that, if you like, that health MOT. The other couple of areas then just to note are in terms of our suicide prevention work. So the latest data that came through showed that we were better than the England average in terms of suicide rate in Reading, but we set ourselves quite an ambitious target and it's not yet at that target. That data gets evened out over a previous 3-year period, so it's very historical. And one of the things that I do in collaboration with Thames Valley Police is we have a real-time surveillance kind of programme so that at the point of police being called to a death where suicide is a possibility, we get that notified through to us within the council, and we don't wait for the months and months of coroner's report and then data being published to look at what's happening with suicide. And over the lockdown period, pleased to say that we have not seen an increase in suicides locally, which is good news. And there's various bits of work that we've been doing to be kind of active in the suicide prevention agenda. And slightly more broadly, we've talked about mental health already today, and with World Mental Wellbeing Day tomorrow, it's a timely reminder in terms of their theme for this year, which is better mental health for all, and that being an important focus kind of more broadly at this time where undoubtedly we've had unprecedented kind of mental health challenge, particularly due to lockdown. And then the final two things to say on the reducing alcohol to drinking at safer levels. people continue to successfully come through treatment with our drug and alcohol treatment provider, which is a good news story and not reflected in these numbers, but we know that they've had a significant increase in the numbers of people in treatment over the last few months as they've sought to be supportive and responsive to the need in Reading during lockdown. And then the final indicators that were updated this time around were to do with dementia. And because of the furloughing of National Dementia Friends staff, and also because of changes to access to primary care, the indicators there are not at the target level, but those are anticipated to be resolved as we move forward, and there's more of a business as usual time period that the data reflects. So there's fuller update against every priority area within the report, which I'm not going to then kind of go into further at this point. But if there are any questions, I'm happy to take them.
Thank you, David. Any questions or points that anybody wishes to make? We've only got 8 minutes left anyway, but thank you very much for that. Yeah, slightly frustrating that a number of the indicators haven't, sort of stood still. But I actually always really enjoy this report, so I will go on reading it. I suppose the only thing I personally flag is like sort of a concern around alcohol and substance misuse issues. And certainly we know from alcohol sales that the effect of lockdown and pressures people under is leading to substantial increases in drinking. So I guess that's just one area I think we're probably going to have significant issues, and not just in Reading but nationally. So thank you very much for that. I'm sort of doing soberish for October, so I'm doing my bit, and we'll it's going okay. Right, okay, thank you. Unless someone's got anything to add, thank you very much for that report. We're going to make it before they shut down the IT. The other item is the date of the next meeting, the 22nd of January of next year. So thank you very much, everyone. I guess we'll see a number of people, well, most people that are on here at the next Outbreak Engagement Board when we have that. And I think we've done quite well. Bearing in mind, this is the first meeting back after about 6 months. I think we've done quite well to get through this before the 5 o'clock cut-off. So thank you, everybody, for coming along. And have a great weekend. I was going to say Christmas and New Year, we'll not meet back in January, but I think that's probably a bit too much. Thank you. Bye.
Thank you.